Hello? Can you hear us? Okay. Now we are seeing you, and you want to try to share the screen to see if it works?
Filippo, could you just repeat, please?
Yes. Can you share your screen?
Okay, I'm sharing it. You should see it.
I will put this as feedback for you, huh?
Okay.
So you see partially the screen.
Can you see it?
No, we still see you.
Filippo, can you see our slides?
No, we can keep seeing you. You can see on the bottom. You can see in the bottom right. You can see what we are seeing on the screen. Instead of my, this is my face. This is the. So you can see that you will still see you.
I'll try it again. Give me a second.
Yes, now it's better.
Okay, so now I guess I'm sharing my screen.
Yeah, no, not really. We're just.
He's sharing his screen, but in his screen he is watching us.
Okay. So
Yes.
we see in the background the slides. Okay, very good.
Okay, I guess you'll see the presentation.
Yes.
Okay, Filippo, we are ready, so whenever you want we can start with our presentation.
Very good. We are ready to. Just give me a second.
Stiamo bene adesso.
Ok?
E anche le slide si vedono bene.
Ok, diteci poi quando ritenete che possiamo cominciare.
Ok.
Which one is the?
This one. No, wait.
No. Can't see. It's
Watch it here. Actually.
Okay. Very good.
Okay.
Yeah, just a second. Okay.
So, Filippo, did you upload this presentation on Dropbox?
Yes.
It is already there? Or?
No.
Later.
Allora, noi ci sentiamo.
Ok, Filippo, quando volete noi possiamo cominciare.
Per migliorare anche la visibilità qui in loco, mi puoi mandare sulla mia mail personale la presentazione, così io la carico sul Dropbox e ti posso sentire anche sul loro computer?
Sì, te la faccio mandare un attimo da Tommaso tramite Google Drive, un attimo solo e te la mandiamo.
Va bene, grazie. Okay, we will add during the lessons the presentation, so you can open up on your computer and desktop. And this is the screen. We are live on YouTube, and online we have today the Pisa University. In details, the MES, what is called MES, Management in Health, and he will talk. He will talk about indicators and so on. But I let Bola introduce himself, so to explain better what are also the function of his institution, and then he will keep going on the lecture.
Yeah. So,
okay. The floor is yours.
So thank you very much for this kind invitation. I'm sorry we cannot see you right now, but please feel free to interrupt us if we are not clear or if the connection is a little bit confused. So, good afternoon.
I will be the moderator, so if somebody have a question, they will raise their hand here, and I will stop you and proceed with the question. Is it okay for you?
Thank you very much. Please feel free to interrupt us whenever you think it's necessary. So yeah, good afternoon from Pisa. Thank you for this kind invitation that gives us the opportunity to share with you what we do, especially regarding medical university evaluation. So we will talk about indicators, as Filippo was mentioning beforehand. So just the outline of what we thought might be of interest. So we will start with a brief introduction to explain to you who we are, what we do, and just a quick glimpse to the Italian healthcare system for those of you who are not familiar with it. Then we will go to the core of this presentation through a focus on teaching hospital performance evaluation, and we talk about indicators, about outcomes, and about research activity evaluation. We will work towards what is basically the future of teaching hospital evaluation. So the integration between teaching hospital evaluation and primary care evaluation linked. And finally, and eventually, we talk about the integration between performance evaluation and performance management. So here we have Tommaso and me. We are two postdoc researchers at the Sant'Anna School of Advanced Studies in Pisa. It's a publicly owned university in the center of Italy, a small but very tough university. And within the university, we work for the so-called MES lab. This acronym stands for management and salute management and healthcare. So as you could imagine, our focus is especially on healthcare management. So as any academic institution, we deal with academic research and education, especially executive education. But today we are. Filippo, is there anything you want to add? Is it right?
Yes, keep going, don't worry. I will stop you if there is some question from the floor.
Okay, so as I was saying, the focus of our presentation today is not academic research or education, but it's performance evaluation, our third pillar. But before going through it, just let me spend a couple of words about the Italian healthcare system, because it's pretty different from the Kazakhstan one. So just let me spend a couple of slides on it.
Just one thing. AMU is a medical university. They work also in some clinics, but they do not own any clinic. They own a hospital. And they are interested, of course, in performance indicator in the clinical activity, because you are the main speaker on that. But I think it would be useful for them to have also an overview about research indicator and educational indicators, because they are very useful as well, see that they teach and do research. So,
yeah, we go through.
Oh, okay.
We go through research indicators as well.
Yes, and educational as well.
Yeah, education. We are a little. Just a few minutes, and we go through it as well. So regarding the Italian healthcare system, just some key characteristics. The Italian healthcare system is a universal system, so it's accessible to the entire population, so universal coverage. It's comprehensive. The Italian healthcare system provides the full range of healthcare services, going from prevention to rehab. It's almost free of charge at the point of delivery, except for some kind of co-payments in diagnostic and pharmaceuticals, and it's mainly financed through general taxation, as it's a beverage model. So some key facts: Italy counts about 61 million inhabitants against the 17.5 of Kazakhstan. Italy is slightly richer than Kazakhstan, with a GDP of 38,000 per capita. I'm talking about US dollars, against 25 in Kazakhstan. And most important, Italy is older. So from the epidemiological point of view, Italy is very different from Kazakhstan, as we have a median age of 45 years against 30 years in Kazakhstan. And Italy is divided into 20 regions that have kind of administrative, governance and political autonomy, as we see later. Basically, 9% of GDP is allocated to health spending, again, mainly in line with the OECD spending, and we spend in absolute terms a little less than OECD. And as you can see, main spending, mainly 80%, is public spending. Basically, talking about resources, human resources, we have a number of nurses that is slightly lower than OECD, and in contrast, we have more doctors than the other country of OECD. This is just to give you a quick overview. In general, our doctors are salaried, so they work as civil servants, despite the GPs and pediatricians, who are independent professionals. Just a slide on organization and governance of the system. Our system is organized in 3 levels, so governance of the system is managed at national, regional, and local level. So regarding the national level, the Ministry of Health and Ministry of Finance, they define what are the core health benefits that need to be granted uniformly across the country, and they allocate to the 20 regions the financial resources to organize those core health benefits. Regions are financed through capitation, basically. And the Italian Parliament defines the legal framework within which regions basically move. So this is the national level. Moving to the regional level, regions are actually in charge of organizing and delivering secondary and tertiary healthcare services. So regions are the key players in the healthcare system. Since the first 90s, actually, they were granted more and more autonomy. So now what you see in Italy is that there are basically 20 different regional health systems, different health system. So take into account when you want to study performance evaluation in Italy. Third level, the local level, we have three main authorities. So the first one are local health authorities. So local health authorities are geographically based organizations, and they are actually responsible for delivering public health, community health services, and primary care directly, and secondary specialist care through either directly managed facilities or by commissioning services to public hospital institutions or private providers. So the second local level institutions are public hospital institutions, and they often cooperate in Italy with medicine schools, and they work as teaching or university hospitals, or third institution private accredited providers. So today we will focus on these second these second institutions, so teaching and university hospitals. So we will focus on them, and we will focus on how to evaluate them. So when we talk about hospitals in Italy, we have three different kinds of hospitals. So the hospitals that are directly owned and managed by local health authorities. Secondly, we have public hospital institutions are often cooperating with universities, and so they work as teaching hospitals. And third, we have privately owned providers. Accredited means that they work for the public system. So, because of this complexity, since 2008, 15 regions felt the necessity to cooperate in order to create a performance evaluation system in order to benchmark their activity and against the other regions. So we will talk about this system and how this system deals with teaching and university hospitals. So this system has some main characteristics. It's comprehensive. It mainly relies on already existing informational flows. Further develops a managerial approach on KPI, so key performance indicator selection. When you say that it's comprehensive, this system is made of about 300 indicators, and those indicators cover 6 areas of analysis. So health status, regional priorities, healthcare performance, user satisfaction, staff satisfaction, and financial performance. So it's a very large performance evaluation system. And it focuses on regional performance at first. Secondly, on health authorities, so you can see the performance of each teaching or university authority or hospital within the system. You can put performance against the others. And third, it offers some performance evaluation about subunits within health authorities. So this is a quick overview of the system. As I was saying, it basically uses already existing informational flows coming from emergency departments, from hospital discharges, from drug delivery, from specific service, from balance sheets. So basically, this system collects all those information coming from different sources and compares and systematizes this information. And I was saying that it adopts a managerial approach. This means that these KPIs, those indicators, are selected because of their capacity to actually steer managerial choices, and they are devised to be reproduced by local units and adapted to local contexts. So today we will see some indicators. You need to know that those indicators could actually be reproduced in your local context. So many applications of these characteristics. This system is very easy to implement even in different contexts. It's very cost effective because it it relies on already existing flows. It supports capacity building because it relies on people elaborating those indicators. It's very easily adapted to local peculiarities, and it can be, and it has been integrated with planning and control mechanism, as we will see later. And it's very easy to be communicated. This system can be freely accessed through this website. Anyway, we will lead you within the system, and in the system you will see different reports in PDF. You have all the tables, you have all the Instagrams, those Instagrams on the corner of the screen. Those Instagrams are basically local health authorities or health authorities, like teaching hospitals. So you have the performance of each teaching hospital compared against the others for about 100 indicators regarding teaching hospitals. And performance is basically represented through this dartboard that you can admire with the bottom right corner. So in 2014, we actually printed an English translation of our report. So if you'd like, we can send it to you, all the description of each indicator in order to go through each of them. And as you can see,
here everybody is saying yes.
Yes.
Probably more than one copy, because here today we have a representative of different universities. We have other cities like Simei or Almaty, or other institutions in Astana like Nazarbayev University. So if you send some of them, it will be very appreciated.
Yeah, sure. We will send you today the PDF copy, and then we'll send you the printed copy. I'm sorry that it's a 2014.
PDF is fine. Paper is going to take 2 years and it will not be affected. Don't worry, PDF is fine. And can I remind you if you can send the presentation by email, because a lot of people are at the bottom of their room and they cannot see the slides very well. So this way they can follow you better.
We share it with you, Professor, on Google Drive.
Okay, I will check.
I hope it. Okay, let us read the slides as arrived.
Ok, verifichiamo.
You can.
Sorry, I can see it.
Vai avanti.
Okay, so as I was saying, the representation is very straightforward. So it's on dartboard. So in this case, you are seeing, for instance, in 2016, how Toscana performed against Bolzano and how Bolzano performed against Lombardy. If I'm not wrong, two of you come from Friuli Venezia Giulia.
Yes.
In Italy. So for this is the dartboard Friuli Venezia Giulia had in 2016. It's very straightforward. See how vaccine coverage can be a criticality and on the left side. And as I said, this system both offers an overview of the region itself, but you can go through it and see specific qualities are for. In this case, it's the integrated teaching authority of Udine. And in this case, you have the 2016 performance. Now, Tommaso will go through it, but I just wanted to give you an overview about the system. So, if you have any questions and queries about this introduction, I would move towards the focus of the core business of this presentation. It's actually evaluating how we evaluate teaching hospitals.
Do you have questions?
Okay, good morning, everybody.
Non ci sono domande, potete andare.
Okay, good morning. Thank Okay, thank you. So I'm going to go through the presentation and on the focus of the university hospitals. We will see who are university hospitals in Italy, and then we'll have some insights about how they perform against the other kind of hospitals, and then we will share with you some insights about the future perspective and the trade-off that we can have between trying to focus the university hospital and the need to integrate this performance evaluation with also the other care services. As Federico said, we work with 13 regions. In these 13 regions, we have 27 university hospitals. For university hospitals, of course, we consider those hospitals that are directly integrated with medical school. And in the Italian healthcare system, this university hospital can be public or private hospital that are integrated with the public or also private university medical school. Usually, as I stated also before Federico, these hospitals are autonomous organizations with respect to the local health authorities, the geographical entity that organize and provide services in specific geographical area. And this, as we will see also discussed later, creates some artificial barriers also to the coordination with local health authorities. And then these hospitals, of course, are very particular because they have this threefold mission that can be considered independent and conflicting somehow, and has said also by Smith and Richard in 2000 and 2002, this threefold mission can be considered a super complex mission. And of course, it is divided in care, so as the other general hospital, this hospital provide care, and they are usually also accredited as a referral. They also have to provide improvement in our knowledge through research, and they have the very important mission of educating the next generation of health professionals. Moreover, in Italy, they receive specific additional financial resources. At the national level, there is an increase of the tariffs that the university hospital receive when there is the reimbursement of the so-called interregional mobility. So when a patient goes to a university hospital in another region, but also at the regional level, the regional government usually provide an additional resources through an increase of the reimbursement of the DRG tariffs, or directly giving some specific funds related to education, research, or to function linked to the complex care. In this sense, these hospitals are very interesting, also from us, from our point of view, we work on performance evaluation. We are autonomous organization with some barriers with the other health authorities. They have this particular mission, and they receive also specific financial resources. So in this sense, we saw some advantage somehow to have a specific focus and benchmark among university hospitals, because of course, especially because they are a referral center for complex care, but also because they are somehow a research-driven environment for introducing some innovative tools about performance evaluation, with particular regard to quality and outcome. And we also want to somehow stress with this focus on university hospital a sort of complete that we receive. So in this scenario, what we usually what is the work of the hospital in particular? Of course, we provide some specific indicators for the threefold mission, in particular for the research activity, since as we in Italy we have some problem about indicators of education because we have a very poor about that. And so we have a specific focus on research activity, but on education we miss a lot of data at this moment. We hope that in the future this gap will be closed. And of course we will see a lot of indicators about efficiency and etc. Indicators about the highly complex care they provide, such as cardiac surgery, vascular surgery, neurosurgery, etc. And then as the environment to also explore and research new performance evaluation tools. We are providing for them also a new evaluation of outcome and quality. We will talk about it. What about the indicators that you can find also in our reports and PDF or directly in our website? For the University of Italy, we provide and calculate and benchmark among these 27 university hospitals indicators for some areas that need mission. So some indicators that try to understand whether these universities are following the expected goals. Some indicators about efficiency, so I try to understand if we are using we are maximizing the utilization of the resources. Some indicators about the organizational appropriateness, the core organizational appropriateness, the use of the appropriate care settings, for example, the surgery instead of ordinary hospitalization, for some particular cases in which they have be as good as in the different care settings. And then we have about quality of care, in particular cost, in particular focus on different care pathways, in particular mental health, oncologic pathway, maternal care and emergency care. And then of course we have some indicators about the economic and financial perspective, usually calculated from the balance sheets. The other indicators are usually, as Federico said before, through all the available administrative flows that all the region has in Italy. And in total we have for the hospital, for this hospital a benchmark for 100 indicators. I'll show you some example of this indicator for each area that we knew before. I consider that, of course, for a lot of time we cannot see all these indicator cases. Is there any question at this point, or can we move on to the data?
Yes, no?
No, okay.
Did you have any questions? You can go ahead. There are no questions.
Okay, thanks. So about mission, some indicators about mission. As you can see, we have 4 indicators that are in particular dedicated to understand whether the research activity of this university hospital can be considered good, and we have in particular also an indicator that is the second one, average number of publications for physician, that is of course a sort of indicator about productivity. And these 4 indicators try somehow, and we will see the data and how they are calculated, try to benchmark the capacity of the different universities to provide a publication and quality of publication. Then we have 2 indicators. One is the percentage of high complex care delivery for patients from other regions. that can be considered a sort of a proxy of quality of care, because usually each patient is starting to move from the south of Italy to the north of Italy, and have a sort of a very long journey, because they from the south to the north, or from the north to the south, it's 1,000 kilometers of journey. So when patient decided to usually it's because this university of the to be calculate the percentage of this understanding from patient coming from one particular sort of inequality from the patient point of view. And this is the same for the percentage of voluntary discharges. Let's say the patient decided to leave the hospital and the medical advice that could be in the opposite way, a proxy of the inspection patient has with respect to hospitalization. We have some publications, some studies also about this link between patient satisfaction and voluntary discharge. So we know that it is a very good proxy of patient satisfaction. And then of course we have an indicator about financial sustainability that is linked monitor and benchmark also the financial sustainability, and these indicators benchmark the overall hospital cost, the number of hospital admission, and the number of admission are weighted for the DRG point. The DRG point is somehow it is linked to the complexity of the hospitalization. In this sense, we can take into account the different case needs provided by the different university hospitals. Then we have indicators about absence rate, so the number of absence, the percentage of days in which physicians are not at work. And then we have an indicator about organ donor procurement, that is in particular considering the mission of the university hospital, because they are usually the referral center for the transplants, and so university hospitals are evaluated in considering the provide this kind of process in our healthcare system. So let's see some data with our you can see all the list of our university hospitals. We are calculating indicators also from
I have a question.
Please.
We have seen that there is absence rate. What do you mean and
Yes.
how do you calculate absence rate?
Yes, we take the number of days that for which the physician should be at work, and then we simply calculate the number of absence on the daily work the physician should provide to the university hospital.
And how many days are you calculating? 7, 6, 5?
Overall on the year 250 days of work.
Yeah, it's a full-time equivalent as generally defined by OECD, and of course in the numerator we depurate the number by holidays, by normal or kind of vacancies, but we include strikes. We include some kind of specific grants if Italian legislation has, we call it Law 104, meaning some kind of actually grants that you are, as a worker, as an employee, are entitled to have. Just to give you a quick glimpse, it goes from 6% to 14% among the Italian regions. And let me say that we tried to perform an optimization procedure. That means that we tried to calculate how many people would each region gain if their absence rate would be the best performance in Italy. Let me say that one region, Apulia, would gain 1,000 people out of 30,000. So if employees in Puglia had the very same absence rate than the best performance, that is Veneto, 1,000 people, 1,000 employees would be gained for this region. This is why we want to monitor this rate. Let me just add one last thing. Together with those indicators coming from basically coming from administrative flows. In this case, absence rate is drawn from data coming from the ministry, actually from the labor ministry. But basically, we integrate those indicators with other indicators coming from surveys. So we have just concluded, just finalized a survey. We call it the internal climate survey. So we have just interviewed all the employees in Apulia, all of these 40,000 employees, in order to listen from them why they are absent, actually. So in order to basically the motivations behind their behavior at work, and we perform those surveys across those 15 regions. So this year we performed this survey in 4 regions in order to listen to the employees.
One more question. When you say average hospital cost per weighted case, you are referring to the to what weighted case? How do you calculate that?
In the numerator we have the cost coming from balance sheet of the hospital, the university hospital, and in the denominator we have the number of admission weighted for the diagnostic related group weight. So each DIRG has a point, a weight that is linked to the complexity of the case, and so we multiply the number of admission of each admission for its DRG point, and in this sense, at the denominator we have the sum of the DRG points. It's the number of admission weighted for the case mix.
Okay.
In order to improve the benchmarking
the case mix. Okay. And one last question, and we let you go. It's organ donor procurement. Why is this so important?
Yes, it's important because in university hospital are referral center for transplants, and in this sense we try to understand whether all the process that usually starts from local, directly managed local health authority hospital in the peripheral area, not only in the city centers where usually university hospitals are located, but throughout the regions, in all the kind of hospital, private, public, university or not, there are some, of course, when the process of donors procurement starts, but it ends usually at the university hospital, and it's the university hospital that is accountable in the sense to provide a good and effective process of donor procurement throughout the region. And in this sense, we use this indicator in the area mission for university hospital, because we want that they work together the other. We want to monitor also how they work with the other hospitals as a referral center in the sense of a hub-and-spoke network in this process.
Thank you very much.
Okay, good. So we will see some data just to have the sense of also the variation that we have among these university hospitals. This is the impact factor per physician, considering the three-year period from 2013 to 2015. And as you can see, the average impact factors starts at vary from the 3.5 of Azienda Sanitaria Universitaria Integrata di Trieste on your left, and to the more over the 15 points. This indicator is simply calculated taking all the publication of the university hospitals. We link the impact factor of the journal in which the publication is published to the article, and then we just calculate the average value for each university hospital. So it is a first proxy of the quality of the publication. Whereas this indicator is more about productivity, so it is simply calculated as the number of publications divided for the number of physicians in each university hospital. And also in this graphic, you can see how Padova, that accounts for a very good performance in the overall quality of the publications, has a very good results also in the productivity indicators, with somehow Trieste was not so well in both of the measures. But the problem somehow is that the different university hospitals can also publish in different subjects, and each subjects and disciplines usually has a very different impact factor. So somehow there are some specialty or some categories for which the impact factor is 10, the average impact factor of the journal is 10, and some other specialty for which the average impact factor is 2. And so to take into account also these different differences, we have also two different indicators that use a sort of international benchmarking. So this is an example. The Lancet, the journal citation report include the Lancet in the category medicine, journal and internal. And this category, considering all the journals that are classified in the medicine journal internal, as a median impact factor of 1.067 and an average impact factor of 3.8, about 3.8. So what we will do? For each university hospital, we assign to each publicator the impact factor of its journal, as we seen before for the other indicators. But then we compute for each university hospital the average and the median impact factor of each its category, specialty, and then we compare the university hospital impact and the average or median impact factor for that category with respect to the international benchmarking for that category provided by the EasyWeb. That is the most important, database about publication. And then what we do, we sum up the percentage, so the number of categories that each university hospital, for which each university hospital has an average impact factor higher than each international benchmark, the impact factor of that specialty provided by EasyWeb. And in this sense, you can see how Padova, Careggi, and Verona has more than 75% of their categories are high after the average international benchmarking, whereas Azienda Sanitaria Universitaria Integrata in Trieste on your left has almost 50%. And this is calculated for the average impact, comparing the average impact factor, whereas this other indicator is the same indicator, but in this case the benchmark is the median and not the average. And as you can see, we can say that all our university hospitals, irrespectively for the variation that we can see as a good performance, because also Ospedale Uniti di Foggia, that is the worst, let's say, performer in this indicator compared with the other our university hospitals, almost 75% of specialty that report a median impact factor higher than the benchmark. So even the worst performance in this indicator has a very good performance compared to the international benchmark. So with these four indicators, of course we are developing and working with the regions to try to share on criteria for additional indicators about research activity. Nowadays, the research activity in our performance evaluation system is monitored and evaluated through these four indicators. I don't know if you have some question, or we can just move on the other data.
Do you have any questions?
Yes, please.
Do you?
Can I?
Yes, please.
Say, for example, university, yes, have some clinical bases in Italy.
Come over here so you ask directly on the computer. Come.
Okay. And university control, yes, how many publications they have, yes, and they have power, yes, power to controlling the publication rank, yes, among physicians in hospitals. For example, in Kazakhstan, it is another situation. Universities don't control publications rank.
They can, but they don't do it. Not just a question, I'm just trying to understand the question.
Okay, sorry.
In Kazakhstan, they publish on journals, sometimes. Sometimes. So, and these journals are public. So if I want to check, I can double check. The point is that nobody controls that. Double checks how many publications.
For example,
actually,
who work in clinics, for
example.
In polyclinics,
because he's talking now about university polyclinics.
Universities.
Yes, but they do it also in other type of hospital. She's one of the students here is asking, but do you control this indicator only on university polyclinics or also in normal hospitals?
Now, these indicators are calculated just for university hospital, but we consider the publication of university hospital of both university physician and physician directly hired from the hospital. So let's say in Italy, the university hospital are usually an integration of a public hospital with a medical university. So in the university hospital, we have some physicians directly hired from the university and some physicians hired from the hospitals. In this sense, we can consider that research can be the mission just of the university physicians, but in what after we discuss, we also we share with reasons, we decided that for university hospitals, all the physicians can be considered dedicated to research, care, and education. Of course, university physicians usually provide works more hours on research and education with respect to what do the hospital.
If I understand correctly, you are actually including in accounting also the doctors that are working with the university staff but they are hired by the standard hospital. Is that correct?
Actually, we shared this decision with our partners because we are assuming that universities need to create a cooperation between those two souls. So let me say, the clinician or clinical one and the academic one.
Yes, I understand. So you're actually collecting also the others, because you just said that normal hospitals are not checked, but these hospitals that are collaborating with the university are checked.
Yeah, exactly, because this comes from the previous region Tommaso was mentioning, so that these hospitals actually have in their mission the research.
Okay.
Basically,
one question about this part. But for example, if a department publish an article with 7 names of each, they are all working in the same department of the university, that's count as 7 for the institution. Is that correct?
Yeah, it's correct. It's correct. And let me add that the very problem in calculating this indicator is determining and retrieving the association between the doctor and the hospital, because the same doctor might work in more than one clinic, and at the very same time, when a doctor writes down his affiliation, okay, in the paper, he might write it down in very different ways. So last year we had one single doctor who had 17 publications in Careggi, one of our best teaching hospitals, with 17 different affiliations. So one's calling it Careggi, another one was Hospital Careggi. So we worked together with 2 partners. The first one is, I don't know the translation, but CNR means the Center National Resource Center, a spin-off from the National Resource Center, in order to create this ambiguation between the doctor and his or her affiliation. So this is the first step. Secondly, before disclosing this data, we always send them to each region, and region spread it to their hospitals in order to double check the results. Because of course, when those results come up and come out, they are kind of explosive results.
Yes. We have another question.
Good morning. My name is Elisa Fabro. I am a contractor research at Udine University. I am curious. Where do you publish all this data? Because I have never seen it. Do you have a report?
Yeah.
Yes, we have both we have a printed record that we usually print during autumn, end of summer and beginning of the autumn. But during June, we usually publish the data on our website. And as Federico showed before, but we will send, of course, our slides, so we will have all the link and to access. There is this open access platform, open access website in which all these indicators that we are showing are published.
So we will share with you the slides that are now downloading to all of you. Inside there is the link, but we will give you also the link separately. You can log in. There are all the indicators, and you can click on each area. You will see the different indicators, and when you open up, you can have a look on each single indicators, how it's the protocol of calculation, how it's the different measure of different hospitals or local authorities and so on. And of course it's in Italian and it's not in English, but if you use Google Chrome, he will ask you if you want to translate it. So maybe it will not be perfect, but you can still go through it.
And we will send you.
But Federico said us that he will send a PDF in English where they already translated. It's not the latest version, so maybe there are not all of the indicators, but most of the indicators are there. Is that correct?
Perfect. And in this presentation, in the last slides, you will find our emails and our websites. So should you have any queries about whatever, just feel free to contact us. We are here for you, basically.
Thank you very much. You can keep going.
Okay, thank you. And then I will show these indicators, one of the proxy of perceived quality of university hospital care in this case. And this is, as I said before, we have a study from our colleagues Durante and other authors that provides some evidence that this indicator can be considered a proxy of patient satisfaction. And as you can see, we have a very high variation in this measure that we can start from Humanitas, that is an important hospital in Milan, that accounts almost zero in this measure. And then we have the three on the right. We have the three university hospitals of Puglia, where probably this phenomenon is very evident. As you can see, they have a very high percentage of this of patients that decide to go at all the hospitals without the medical, not in accordance with the medical advice. So this is one of the indicators that we use for the area mission. And then here we have the data on the average hospital cost per wetted case. We said before that wetted case means that we can, in this sense, we take into account the case mix, the different case mix that this university hospital delivers. So this improves the relevance of this benchmarking. And as you can see, we have different starting from 4,000 euro for a DRG to almost the double of the university azienda universitaria Udine. So there is a large variation also in these indicators, but we can see also large variation within the region. Let's say that Auseni, that is the best performer on these indicators, is in the same region of Auca region, that is the fourth in the right, at the right of the graphic, that is another university hospital in Tuscany. So we can see variation between these hospitals, but also a variation within the region. Okay, if there are no questions, I'm going to present some data about efficiency and appropriateness.
Okay.
So for the efficiency, we have three indicators that somehow are linked to the length of stay. So we try to understand if given the inputs, so the installation, we are delivering the hospitalization with a length of stay shorter than possible. And in this sense, we use this indicator, that is performance index for energy hospital length of stay, and how it is calculated in this measure. We compute for each DRG, so for each case, let's say, different case in which university hospital we calculated the actual length of stay for each DRG. Then we calculated the difference from this actual length of stay to the expected one, and the expected one is calculated as the average of the hospitals for that DRG, so it is the benchmark we use. We sum up all the differences for the old DRGs delivered by the university hospital, and we divide the result.
May I interrupt you a second?
Sure.
Okay.
Yes.
For both ways. See, he's always talking about DRG, okay? DRG is a system that codifies all the sickness and the treatment that we can have in the healthcare system. There are different versions. We work with version number 9. Kazakhstan wants to go to number 10 like the United States, but actually is still to number 9. So actually our indicator can be comparable with yours. The point is, and when I mean yours, I mean Italy. But the point is that the collection of this information is not systematically distributed in all the country like in Italy. So the problem is that some hospitals do not register DRG. They should, but they do not do it, or they only do it sometimes. So the problem that in theory we can compare them actually is a little bit more difficult. But there is a plan, and tonight we will have a lecture of Oljas. He comes from the e-health institution of the ministry, and one of their plan is to work on this type of activity based on DRG. So I suggest that you focus how important they are, and you will ask questions tonight to Oljas to understand at which point and how much is the coverage of the system, so we understand if we can actually implement it this year, or maybe next year, or in 3 years, or never. So we understand if we can actually compare or not our indicator with them. Another very important issue is this one. Astana Medical University do not have their own clinics, but they work with several hospitals. And as we have seen, when they calculate in Italy, they calculate with the number of applications, also the doctor that are working in the hospital collaborating with AMO. That means that actually we can collect abstract and impact factor also from these centers. It's true, and I know that you know it in your mind, that they don't publish anyway. So it's like collecting nothing. But actually there is a very, there is a new push from the ministry that is asking to all the research center in Kazakhstan, so traumatologic research center and so on, to create a partnership and create a like the one of AMO and La Sapienza. So it's a special partnership to develop research in these centers. So maybe also for you this information is useful, because some of these centers are coming to us asking how can we suggest them how to do this partnership. Maybe if you are interested, we can put you in contact with some of them to organize a partnership, so they can work with you maybe on publication or other things. And of course they will be supported by the World Bank project. So this is the situation at the moment. That means that if we help this research center that are not AMO, but they work with AMO, and then we go to calculate the same indicators, we can then increase our publication range much more. Sorry
Absolutely.
if I interrupt you, but I think it's important to give information in both ways. Okay.
Now let me just say that I perfectly agree with what you said. Both regarding research, I would say that measuring is the first step in order to improve performance. Secondly, regarding DRG and DRGs, let me say that you mentioned the problem about comparison among and across countries, but let me say that even within a country, we retrieved great differences in how they are actually fielding. What we did, actually, we saw, for instance, that in a region, in Veneto, for instance, they had and they have very specific habits about how they register DLTs. What we did was basically performing a kind of a robustness test about indicators. So we saw how indicators would move according to different practices in registration. And we saw that actually some indicators moved a lot according to how data were inserted into the system. And other indicators, for instance, the indicator Tommaso was mentioning before, these indicators does not move so much according to how data are actually entered or inserted into the system. But I just wanted to say that I perfectly agree with your concern.
Okay, thank you. So this indicator is like calculated for each ERG, and we compute the actual length of stay, and then we compare it with the expected length of stay that is calculated as the average of all the hospitals we have in our system, in our performance evaluation system. Then for each university hospital we sum up all these differences, and we divide the numerator for the number of hospital admissions. In this sense, we can interpret the results of this measure as the average number of hospital days below or over the expected value for each university hospital. And since we do this calculation DRG per DRG, we take into account in this measure also the differences in the delivered case mix from a university hospital and other university hospitals. In this sense, this is the indicator, performance indicators on average length of stay for the accurate.
Sorry.
Please.
Okay. Can you explain what is the case mix? Because yeah.
Right.
Okay. Thank you.
Now, the case mix is, we can say that it's the difference in the case that the hospitals deliver. So we can have some hospitals that for regional, since they are regional referral centers for all the complex care from transplant to the cardiac surgery, neurosurgery, etc., as a very complex average case mix in this sense. Whereas the university hospitals, since they are in some geographical particular positions or other features, they have the complexity of their hospitalization is lower. In this sense, if we work calculating the differences in the length of stay, taking into account which kind of DRG is linked to each hospital admission, we can take into account in the measure the differences in the overall case mix that different hospitals deliver. I don't know if I am clear.
Okay, thank you.
So let me just bring you an example. If I, Federico, if I need a very complex and technical surgical procedure, I will probably go to a very specific and renowned hospital in Italy. So I will probably move to Florence, or I will probably move to Milan in order to have this specific technical, complex and difficult procedure. So, of course, this hospital is expected to treat very complex cases. The name case mix comes from cases this hospital is treating. So when we compare this hospital against other hospitals maybe in the country, probably the cases they are treating is very, very different. So all the indicators basically need to be standardized and corrected, taking into account, as Tommaso was mentioning before, the differences in the cases they treat. It's called risk adjustment in literature.
Okay, thank you very much.
Okay.
So this is the example of these indicators for the surgical cases, and in this sense we can say that the Pisana, the hospital in our town, for each surgical admission accounts for an average length of stay of one day shorter than the average. In the other sense, the hospital in Brescia, that is in Lombardy, for each surgical admission accounts for an average length of stay higher almost 2 days with respect to the average. In this sense, these indicators can be interpreted and read simply as the average day length of stay each hospitals account for higher or lower with respect to the average. And this is the same indicator considering the medical admission. So we divided the indicators between surgical and medical admission just to allow the hospitals to go through the data and try to understand why some university hospitals perform better on the medical side and worse in the for the surgical cases. In this way, we compare somehow the efficiency of the different university hospitals in our network. And then we have a lot of indicators. These are just some examples. For quality of care, we usually use process indicators because for outcome indicators such as mortality, admission, etc., we will see different methodology. We will talk later about outcomes. But for quality of care, for these indicators, we will use a process, somehow proxy for outcome. And in particular, quality of care, we have these indicators about the percentage of femoral neck fracture operated within 2 days. The literature tell us that a patient with a femoral fracture is operated within 2 days. The recovery will be very, very better. And so we calculate the percentage of patients that are operated within 2 days because this is a sort of proxy for mortality in this care pathway. And we also check whether the hospital has operated the femoral neck fracture because sometimes they prefer to not to operate the patient, but also in this case the literature tell us that it's better have a surgical intervention for this kind of fracture instead of a medical monitor for this patient. Then we have an indicator about...
Sorry, un secondo che spiego un attimo una cosa. This indicator, the first one, is one of the more important indicators in Italy and all over the world, because this indicator is calculated at a single hospital, at the local level, province level, regional level, and national level. It's very, very important because it's correlated to mortality. So it's very, very important. And this is one of the most important. Okay? And in the other days we can see other indicators like this that is very, very important to monitor the efficiency and the quality of care of the hospital. Okay? Bye.
Thank you. Then we have an indicator about the utilization of the transurethral technique in prostatectomy, and this is a quality indicator that we share with the region. And then we have a very general indicators that try to understand whether a patient admitted from the emergency department and sent to a surgical ward, a surgical department, has been actually operated. And so we checked whether his cases at the end of the hospitalization can be considered surgical or medical. In this sense, we try to understand if the process of diagnosis and link between the emergency care and the hospital wards is well functioning, or if surgical hospital beds are occupied by patients that will be not actually operated.
Sorry. Why this is very important?
This is important
for diagnosis, no? But it's also important for the cost of the beds, because surgical bed is more expensive than medical beds. So this is very important for the cost efficiency. Okay? Is correct?
Yes, sure. Thank you for that. And then we have some indicators about specific care pathway. We can see for the maternal care 3 indicators about the child delivery. So the presence of C-section, the cesarean section, and this is a very important indicators. The World Health Organization tells us that the standard should be 20% as the standard of this percentage. We will see later the data if our university hospitals are providing this C-section with respect to the standard. And then we have two other indicators, one of the episiotomies and one about the assisted delivery. Just some data about this measure we saw. This is the percentage of femoral neck fracture operated within 2 days. We said before that this is a very important indicator, and as you can see, the variation of our university hospital starts from the 25% of casus sollievo, and we arrive at almost the 8%, more than 80% of ospedalici come Fondazione Macchi. A huge variation among our university hospitals that we consider that they should be the best performers. They are in charge of educating the next generation of our physicians. In this sense, we can consider that a university hospital with a poor performance on this very important indicator is a very important signal also for our policymaker. And okay, this is the data. I don't know if you want to have something from. Please.
Percentage of who had operation for within 2 days, right?
Yes.
So it will be the big one. So how many population are out now? Is it a lot? For example, 80%?
No, generally they have. It's good when it is like higher.
So it's
higher. High. Okay. So when you see these graphs, every day green is good and red is not good. Okay. So it will be the more okay. Okay. Bye.
And this is the data for C-section, the percentage of C-section. As you can see, we have some almost half of our university hospital above the standard of the World Health Organization, that is 20%, and some university hospital that provide good results for this percentage.
This is the contrary of the other one, no? You have okay.
Okay. For the oncological pathway, I'm going just to let you see some data. This is the overall average waiting times, so the number of days that on average patients wait for receive surgical oncology, considering cancer for breast, lung, prostate, colon, rectum, and uterus. And as you can see, the data start from almost 20 days of waiting list, until more than 50, so more than double in the Ancona. And I'm going to show some measure, a specific measure for some of these surgical oncology. In our system, we have all the indicators for each cancer. This is the data for breast cancer. Also in this case, we start from 50 days to almost 50. And this is the data for rectum cancer, and we also in this case we stand on the right at more than 62 months, let's say, of the waiting list.
Yes. It's how many time I'm waiting for surgical procedure. Okay?
Okay, on emergency care, I'm going to show you just some two examples, but let's say that our indicators usually monitor the percentage, the waiting times that patient, depending on the code. We use yellow, green, red, yellow, green, and white code to divide the patient at the entrance in the emergency department.
Tommaso, do you know this code? Yellow, white, red, green.
Emergency?
For emergency. Ah, yes. Okay, vai. Volevo sapere se era chiaro la differenza.
Okay, good, thank you. And so this is one example. This is the percentage of yellow code patients visited within 30 minutes, and in this sense we see that there are some university hospitals that almost arrive at 100%, whereas there are some other hospitals that are under 50%. And variation.
You calculate them when the patient arrived at the emergency room, no? It's correct?
Yes.
Okay. Because they are. Okay.
Yes. If they are from the time of arrival to the time in which they are visited by the physician.
Okay.
And this is another indicator that it's quite similar to the voluntary discharge, that is the patient leaving the emergency department without being seen. So this is a proxy also, let's say, of patient patient satisfaction, and we are trying to study the relationship between this indicator and waiting times of course patient satisfaction in the emergency department. Also in this case you can see how San Raffaele in Milan accounts for 0, and then we have a very somehow high outlier in Ospedale Uniti di Foggia on your right, that in which almost 15% of the emergency care accesses usually go homes without being seen. So a very high percentage of the total, of the overall emergency department admission.
This is monitor the satisfaction of the patient. Okay. If I wait a long time, I go away. I go to another emergency. Okay.
Okay.
Finally, we can see a sort of summary in our dashboard for, this is an example of one of our university hospital. As you can see, we have the different indicators located in different areas. And in this way, it is quite simple to understand if there are some strengths and weaknesses. For example, this hospital, this is the hospital in our town, as you can see, a very poor performance with respect to all the emergency care indicators, whereas in the oncologic pathway we have good results about values delivered for this surgical oncology, but we have a red point for the waiting list. So good quality, but high waiting list for oncologic surgery. And this is the summary we use for the indicators about the university hospitals.
Not good. There is a big problem in Italy for the waiting list. So,
Well, it's quite clear that it's an area of weakness here in Pisa. Okay, let's quickly tell something about how we measure and we compare outcome for the university hospital. So we take into account a list of departments that are in charge of the overall hospital admission in our university hospitals, that are general surgery, cardiac surgery, orthopedics, neurosurgery, cardiology, neurology, internal medicine, and neurology. These departments account for more than 50% of the overall cases in our university hospital, and for this reason we concentrate our attention on these departments. And for these departments, we calculate 5 indicators. 4 measure of outcomes, that are voluntary discharges, 30-day mortality, considering both in hospital and also after discharge mortality, 30-day readmission for the same medical diagnostic category. That means that the readmission is for something that is clinically is likely to be linked to the previous hospitalization. Then we have a return in the operation theater during the same hospitalization. So we try to understand whether the patient has been taken in the operation rooms twice or more than twice during the same hospitalization, and this is usually linked to problems linked to the first hospitalization. And then we calculate for each department the performance index for every hospital length of stay, that is the indicators we saw before in the efficiency dimension. We use a multi-level model. The 2 levels are patient departments. These kind of models helps us to take into account how patients are different patients hospitalized in different departments. So we take into account of the individual patient, and we take into account how the population of patients inside a specific department is usually different with the population admitted in the other departments, and this helps us also to take into account also different capacity and different way of register and codifying our administrative flows. So it's very important to use this kind of model for risk adjust our results.
Sorry, there is a question.
Please. Yes.
Voluntary discharges means that how many people leave hospital during the hospitalization. So I'm not feel good with this hospital and I go to another hospital. I leave this hospital and go to another hospital. It's very important. Change hospital. Okay, how many people change hospital? The other one is the mortality. Mortality in hospital or after the hospital, after the surgical procedures. Okay, when we go home. 30-day readmission is the number of patients that with the same MDC means the major diagnosis. Yes. So it means that I don't. Yes, it means that I have take care of the patient, but not in the right way. Yes. So the patient come back to hospital again. Okay. And the other one is we saw this after is how many days the patient stay in the hospital, because there are in Italy there are many standards of efficiency of the hospital. So a patient, for example, for laparoscopic procedures, they have to stay minus than 3 days, or from 0 to 1 day. So it's the hospital, okay? Because 1 day is enough for a laparoscopic procedure, okay? And this is this type of indicator. But the most important is the multi-level model, no? Because we have both patient and department in the same. This is the. Can you explain again risk adjustment?
Yeah, sure.
Okay.
So, yeah, we try to avoid the. So when we compare the different results in these 5 indicators, especially for the 4 outcomes, let's talk about the 4 outcome indicators. When we compare these indicators, of course, the differences across the university hospitals can be, of course, linked to the different complexity of the patients they care. So we must, in order to compare the results, we must cancel out the effect of the complexity of the patient, the differences in the complexity of the patients across the hospitals. And to do so, we include in our model some variables that try to avoid the effect of the differences in the complexity of the patient. And for this reason, we use gender and age, because we know that the more the patient is old, the more usually it is complex. We include a variable that map if the patient has been admitted during hospitalization, also in an intensive care unit, because if the patient has been in one of these departments, it probably has some clinical issue, and so its pathway is clearly more complex than the other one. We use also 30 variables to understand which kind of comorbidity. If the patient has a heart disease, if the patient has a pressure disease, blood pressure disease, respiratory disease, etc. And in this way, we cancel out the effect of these disease differences in the patient if they have this disease. So we take into account, and we can compare the results irrespectively the difference in the case mix again, as we said before, the different hospitals have. So, what are the results of this model? We have an odds ratio. So 1 is the value for which the expected. Let's talk about the 30-day mortality. If an hospital has results equal to 1, it means that the expected the expected mortality is equals is equal to the actual mortality we saw in that department. In this sense, there are no difference between the expected and the actual mortality. If the indicator is higher than 1, it means that the numerator is higher than the denominator. So the actual mortality is higher than the expected one. And of course, if the indicator is lower than 1, it means that the numerator is lower than the denominator, and that the actual mortality is lower than the expected. We of course take into account the confidence interval, which means that we can understand if the difference is from the expected value, that is 1, is a statistically significant different from 1. In this sense, at the end, we color the results using red if the mortality or the other indicator are significantly higher than the expected, and yellow if the difference with expected is not significantly different, and green if the result is significantly better than the expected. And finally, we provide to each hospital and to each university hospital this report. You can see the different departments we missed before, so cardiac surgery, cardiology, general surgery, internal medicine, neurosurgery, neurology, orthopedics, and urology. And in the columns, you can see the number of the first column is the performance index of length of stay. So it is the number of days that on average the department has in the length of stay, higher or lower with respect to the average. And then we have the 4 outcome measures, colored, as we said before, in yellow, green, or red, depending on the results we obtain. In this sense, and this summary is provided both at the department level, but also at the individual ward level, because especially in the university hospital organization in Italy, but also in the other country, usually there are more than one ward, especially for general surgery and internal medicine. And in this sense, we provide the results detailed also for the individual wards. And as you can see, the general surgery of these university hospitals, this university hospital has 4 wards of general surgery, and 3 of them has a red dot. And it means that, of course, the heads of these 3 general surgery should organize an audit to understand why the 30-day admission rate of their patient is significantly higher than the other university hospital. Then the other general surgery of the other university hospital, because each department is compared with the similar department. So general surgeries are compared within the group of general surgery, the cardiology are compared within the group of cardiology of the university hospital, etc.
Do you know which is an internal audit? Audit. Yes. Okay. It's important because we compare the same type of department. So it's very important because there are difference between the ward in the same department. So there is something that is not, we have to investigate in this case. And internal audit is a good instrument to take this.
Excuse me, could you explain that?
Internal auditing is a tools that you can use, generally we use this in the hospital when, for example, there will be near misses or some risk. It's correlated to the risk management.
Okay.
Internal audit permit to the risk manager to know where is the problem. Okay. If you want, we can speak about internal audit. For example, we'll give you an example.
Now it's clear, so because in Italian
we have also an example of practical. We work at the AD of Viterbo, and we have the schedule of the internal audit of the AD, if you want.
Thank you very much. Bye.
Ci siamo?
I just add something about the risk adjustment, just to have the interpretation of the red dot or the green ones. So if I am the head of an orthopedic department that has a red dot on 30-day mortality, it means that my patient has a higher mortality that is compared with the other orthopedic department of this 27 university hospital, but this is not explainable by the differences in gender, age, number of patients admitted in an intensive care unit, comorbidities of my patient, or complexity of the cases I treated, with respect to all these variables in the other orthopedics department. It means that the doctor is probably linked to other sources and other causes that can be, of course, a lot. In this sense, it is very important to have an internal audit, as we said before, and you said before, with the clinical risk manager, because probably, usually it is not something linked to the clinical practice, but it's usually linked to the organizational care pathway within the hospitals. And in this sense, the presence of the clinical risk manager in this internal audit, in which the head of the departments take the clinical records of the patient that they are dead and try to understand which kind of care pathway they have inside or outside the hospital before the admission, and usually there it can be found the actual cause of that red dot. Okay, this is what we do. So a university hospital, sorry for moving off the slide, will have two kind of final summary. The dashboards with the different indicators that we saw before, ordered with the different areas, and this summary about the outcome indicator. This is what we provided to the CEOs of our university hospitals. And to conclude my speech, I would like just to add something that we have saw a specific benchmark among these 27 university hospitals, but we are also trying to understand whether these university hospitals are performing with different performance results with respect to the other hospitals. And I want just to share with you the results of one of our research in this sense that explains, so that has some evidence, provides some evidence that university hospitals, at least for our, considering our data, and also some indicators of outcomes that we collect from another performance evaluation system that is present here in Italy, that is the National Outcome Evaluation Program. We saw that for 28 indicators of both performance efficiency, patient satisfaction, and outcomes, there are no difference in terms of performance results among general hospitals led by local health authorities and our university hospitals. In this sense, we want to send a sort of message saying that it is important to provide benchmark focused, performance evaluation system focused on university hospital, but we need also to provide a benchmark with the other kind of hospitals in order to let's say, hire and incentivize a sort of continuous benchmarking comparison, not only among the university hospital, but with all the hospital, with all the providers that provide hospital care. This is the final about we need to balance a focus on university hospital and a focus on also the integration with also a benchmark with the hospital, kind of hospital.
Okay, so far, Tommaso, my colleague Tommaso has brought to you the state of the art of the evaluation of the teaching hospitals evaluation. So I would ask to you first if you have any questions about what Tommaso told you, and second, if you can give us 10 more minutes in order to explore what's next. So basically, what's the future perspective about the teaching hospital evaluation? Great. Go ahead.
I have a question regarding to the measurement. So how often do you measure the indicators? And I just want to know that.
Okay, we for the network of regions in which we work, we provide an annual update of the data. So each year, usually between May and June, we publish the data of the year before. So in June 2017, we published the data of the year 2016 of our region and health authorities.
But as Tommaso and as we previously mentioned, those indicators are intended to be reproduced at local levels. So basically each region is monitoring those indicators with a quarterly lag, more or less. We are in Tuscany, so we cooperate with the Tuscany region, and we calculate a subset of these indicators monthly. So each month we monitor how those indicators are going.
When the regions come with the data, okay? For the data. Ok? Puoi andare avanti,
Ci potete dare ancora 10 minuti solo per appunto chiudere questo discorso?
Sì, dale.
Okay. So just we wanted basically so far we thanks to Tommaso, we've explored evaluation basically regarding the organizational structure, so related to teaching hospitals. Now, what's happening in Europe? In Europe, we are seeing that epidemiology is moving. So we need to basically move from an evaluation strictly related to the organizational structure to a kind of care evaluation. So we have to take into consideration how different actors interact in order to grant high quality healthcare. So not only teaching hospitals, but all the other actors. So we need to evaluate how these networks are working. So we are basically moving to what we call a pathway-oriented evaluation, and I would like to go quickly into this. And then briefly about a case study Tommaso has conducted or basically conducted some years ago. So regarding the first point, I was saying that the demand side is rapidly shifting from a kind of acute oriented care to a chronic condition care. So it's as I showed to you before, in Europe and especially in Italy, the average age is more or less 10 years higher than in Kazakhstan. So basically we need to redesign our offer in order to take care of these demographic and epidemiological shift. So of course the activity of teaching hospitals needs to be reframed accordingly. So from being a center of excellence in itself to be a center or a hub in a network of healthcare offer. So basically, when we compare to the strategic literature, basically we can say that the strategic focus in healthcare, and I'm referring to Europe and the US, that are contexts that I know better. Basically, we are assuming and we are seeing a shift in the paradigm. So we were talking about fee-for-service since the 90s. Now we are moving toward a new way of payments of providers based on risk sharing and rewarding. We were talking about incentives, and we were talking about incentives linked to treating people. Now we are talking about incentives about preventing people from being treated. We were focusing on patients. Now we are focusing, or we should focus on population. We were talking about providers. We were talking about standalone providers, and I'm mentioning teaching hospitals. Now we need to move towards joint contracting, about networking, as I was saying before. And we are talking today about information. We basically are used to talk about a retrospective attitude about information. So using information to test and to monitor what's happened. Now we need to use information in order to predict what's going to happen or what we want to avoid to be happening. So this is how the strategic focus in healthcare is basically shifted. And of course, the teaching hospitals activity and the teaching hospital evaluations needed to be reframed according to this shift, this strategic focus. So let me just I will shift the slide to move to this one. So now what's happening? Now we have different providers. Basically private accredited providers or hospitals related to local health authorities or providers like GPs in the local health authorities, and then we have teaching hospitals, specialists in teaching hospitals. But who is the real care manager? It's the patient. I mean, now so far the patient, at least in Italy, is in charge of coordinating all those different providers. Let me mention, we performed in 2012 or 13, I don't remember, but basically it involved GPs, so general practitioners in Tuscany. And we asked to GPs and to patients, we asked them who is in charge about sharing the information between GPs and specialists. So who is in charge of care management? And this blue light, so this blue light represents patients. So patients are in charge of data sharing. Patients are currently the real actors of service coordination. Okay, so basically we always talk about healthcare paths, continuity between hospital care and primary care, about patient-centeredness, but what's happening is that basically we are still measuring and assessing quality, efficiency, and appropriateness, we will focus on setting of care. So we talk about performance of teaching hospitals, we talk about performance of single units, we talk about performance of single local health authority. We deem necessary to basically reverse this strategy. So when I say we, I talk about our lab, but I'm talking about the OECD and the European Commission and the World Health Organization. So all these big institutions are saying, okay, it's nice evaluating structures, but we need to move towards a population-based perspective. So even evaluation needs to be reframed accordingly. So you, as an evaluator, you need to shift towards an evaluation that takes into consideration all the care pathway and not just a single phase within it. So basically, we need, I just skip these slides because we are a little bit late, but basically the point, the goal, the target we are focusing on is overcoming the traditional organizational boundaries. And in order to do so, we have started evaluating hospitals, including teaching hospitals, according to healthcare pathways. So we have designed new pathways, so the maternal care pathways, the oncological care pathways, the mental care pathway, and the chronic disease care pathway. According to those pathways, we have reframed the key performance indicators in order, and I show you how, in order to show how the system, not just an hospital, but the system itself, is taking care of the pathway in its complex. So let me bring you an example. These are the indicators that are included within the maternal care pathway. And so we have different phases. So we start from pregnancy with some of the indicators Tommaso was mentioning before. Then we move to the delivery phase, the first life year, and then we have some indicators relating to from the first to the 14th year of life. So, according to this new approach, to this new aggregation of indicators, the previous representation. So, this, as you see at the top, this was how we performed the evaluation. It was how Careggi, the hospital, was performing. Now, we're moving to this. So, how Careggi, together with the other providers, is moving, is cooperating in order to grant the maternal care pathway, cooperating with the other providers. So, in this case, we call it the pentagram. The pentagram represents pathway according to the different phases, but it doesn't relate to a single provider. It doesn't relate to itself, but to different providers who share the responsibility of providing this care pathway. So if we focus on the pentagram, so on the performance about maternal care pathway in the center of Tuscany, where Careggi is, you can see how this pathway performs, and if we magnify a single phase, as you can see, we are showing how, in this case, the indicator relates to C-section deliveries, how Careggi performs together with the other hospitals. So the first dot, the white dot, is Careggi. The second one are the other hospitals. So using this new representation, basically what we are trying to say and to show is how teaching hospitals are integrated together with other providers in order to provide not only hospital care, but care in itself. Okay, so in these pentagrams, what you see is both hospital care and primary care. So this goes back to the title of this presentation. So medical university is guaranteeing a clinical excellence and primary care. So, for instance, these are the pathways, the maternal care pathways for the 15 Italian regions. So as you can see, this is Basilicata in the south of Italy, this is Bolzano in the north, Emilia-Romagna, Liguria, Lombardy, outperforming. You can see delivery is the first phase, first life year the second phase, more than 1 year is the third phase. So Marche, Apulia, Trento, and you can see that teaching hospitals are within the pentagram, and you can assess which phase of the pentagram of the process is performing better or worse, regardless of the hospital actually providing the specific service. This is Umbria, this is Veneto, and this is finally Friuli, Venezia Giulia. As you can see in this case, all those red dots regards vaccine coverage. And then we move to Udine. And in Udine, again, we can have a focus on how maternal care service is provided in this specific area, both by teaching hospitals and by local health authority hospitals. In this case, there are only, well, in other areas they are jointly evaluated. So this was an example in order to see what's happening next. And I was mentioning just, I would pray you to give us just 5 more minutes for Tommaso to just quickly introduce to you a case study regarding how in practice this process, this shift actually worked.
Yes, thank you. So just a brief...
Just a moment, please, just a moment.
Yeah, sure.
In Italy now we work in every hospital for pathways. It's very important because pathways, for example, maternal pathways, is not, we can monitor not only the pregnancy and then the childbirth, okay? It's not finished because the pathway take care of the woman when we discover to be pregnancy, then during the pregnancy, when she go to the hospital for the birth of the baby, after the birth of the baby for the vaccination, the first year of the baby, and so on. So it's a very, very long time pathway. It's not only one thing. It's not only the birth of the baby in the hospital and it's closed. No, it's very, very a big time of they take care of the woman. And this is very important because with the pathway you can create a network within the different experience you have on the territory. So between a hospital, between the person who has vaccination, between after for pediatric level and so on. So it is very, very important. And now in Italy we work always for a pathway. It is very important. Huh? It's not follow-up. It's not linked only for a moment of the pregnancy, but it's very long time period that involves many figures and many institutions in this pathway. Okay, it's not only hospital. Okay.
What Kelly is saying that we define where the patient is going during all his sickness. So it's not only about in hospital, if you have to visit or move from one department to another, but it's also outside the hospital. So we have a broader pictures. So also when it's home care and so on.
And Tommaso before spoke about continuity of care. This is very important now. No? It's the continuity of between hospital care and primary care. This is very, very important.
Ok, puoi continuare, grazie.
Thank you. So we just to tell you a brief example of the risk that we can have if we try to evaluate the teaching hospital just considering the hospital phases. We are not saying, of course, that it's not important to evaluate teaching hospital activity. As you have seen, we have a lot of indicators to assess how quality and sustainability and etc. inside the hospital has been pursued. But there are some risks to that we run when we consider just teaching hospital internal phases. And these are very short examples. We are talking about the diabetic foot. Diabetic foot is a major complication of diabetes. Usually after 60 years old, a patient with diabetes starts to have some problems at feet. And these problems after some years, especially if not if the patient are not treated and in the very early phase of this complication can have a very severe outcome, such as the major amputation due to this diabetes-related complication. And this is a very important indicator because it affects, let's say, the overall quality and coordination within the overall healthcare services, because in this care pathway, primary care, they are involved all the care setting, primary care, community care, the family, the hospital care services after discharge in the community setting, etc., home care. So it is a sort of indicator that is a sort of proxy of the overall quality in the healthcare system. And of course, it is, as we say, a multi-provider, multi-professional, and multidisciplinary pathway, and in which the integration between professional and providers is essential to provide to provide good results. In this sense, you can see the map of the Tuscany. These are the results that we saw in 2012 about the major amputation rate caused by diabetes complication in our local authorities. And as you can see, we had Arezzo, which was the best, the national, not only the regional, but also the national best performer, with a rate of 20 amputation rate per million residents. And then we have Pisa, in which there were, in the local authority in which Federico is, in which the probability of this kind of amputation due to this complication was 5 times higher than Arezzo. So our question at the time was why there is such a huge variation, and we try to understand and to spread the integrated care between the different healthcare health authorities, with a particular focus on PISA reality. Just a second, I'm going to show you the results of this analysis. And PISA was a very interesting case, because in Pisa, the university hospital is the referral center for the diabetic foot complications. So there was a sort of paradox to have the worst results in diabetic foot major amputation rate in the same area in which we have the best referral center. And this was due because, as you can see, the blue area is the rate of the different residents in Tuscany operated in Pisa. And as you can see, the Pisa University Hospital performed operation for diabetic foot complication and amputation for all the residents in all the Tuscany. But in particular, there was a sort of incredibly high rate in the very Pisa area. And this is probably was due to lack of integration with the other providers in the Pisa area, and in fact we perform a lot of different measures and indicators, and we discuss them with the professionals here in Tuscany, and we found that in Pisa the University Hospital Diabetic Foot Outpatient Clinic was not always involved in the internal patient pathway by the other department inside the university hospital, and then we have problem in coordination with the other care settings that were managed.
Posso interrompere un secondo?
Certo, certo.
I would like to focus on something very important. We don't have clinics, okay? But there is the project with the World Bank that we will have some clinics, but also especially polyclinics. Here, polyclinics in Kazakhstan means that are ambulatory at the district level. So it's not like Policlinico Gemelli. So the point is that we will create a network of polyclinics. That means that we will work outside the hospital, trying to avoid people to go to the hospital and to be managed in this type of ambulatory or at home. So we are the main competitors of the Kazakh hospitals. It's a different strategy from before. You have to imagine the ambulatory settings and what you call polyclinics have a huge advantage. They cost much less and they see a lot of more patients. At the moment here, all these district ambulatory are run by the municipalities, so they are not under the Ministry of Education, of Health, but they are under the Ministry of Interns. So but we will start to work and create a network of polyclinics. So all these measurement, and when we talk about clinical pathway, for us is very, very, very important, because we want to connect to the hospital and take all their patients, connect with the GP so the patient do not go to the hospital. So our strategy is to steal all the patients from hospitals before they get there and take them when they go out, and keep them at home or maximum in the ambulatory.
Yes.
So you must understand the indicator is talking about, because they're very, very important, and understand how this works. I have also another question from the floor. Somebody was asking me, they see that they, one of their main core business at the moment is education. How do you measure the educational point of view? What are indicators do you use for education?
Okay, let's say for education, as I mentioned at the beginning, the problem in our country is that we have no standardized flows, administrative flow that are collected throughout the different regions. We know, for example, just how many scholarships for the many different medical schools each year the Ministry of University here in Italy provide, but we are not sure even how many students are present in the university hospital, because we do not know if they have finished their scholarship, if they are actually just if they are working in the university hospital, or there is some internal agreement between a university hospital and an hospital linked to local authorities in order to share some students. So about the education, we have a lot of work, there is a lot of work to be done, because we do not have even the basic information to calculate some indicators. Of course, we would like to somehow have a chance to first start to understand where are our students and how much they contribute to the productivity of our university hospital, because one of the main topic in the debate about the performance of university hospital here in Italy is that the hospital that has no students inside the organization, they usually say that the results of university hospital are somehow biased by the presence of a lot of physicians that are not counted in the overall number of physicians that actually work inside the organization. So we would like to start from knowing where students are, and then when we will have this kind of information, we will move from productivity indicators to quality of education. Let's say that it will be very interesting to evaluate education, asking students to evaluate the lessons, the courses, and the quality of the internship they are following inside our university hospital. But sadly, we have a lot of work to do about these indicators in Italy.
Okay, thank you very much for answering the question. And I think it's very important that we have a different chance here, because we already implement Sirius, that is a database for students for e-learning, so they collect a lot of information. We will see in these days if this information are valuable or not to create indicators. So, but this is just to have an overview about these things, okay? Thank you very much. Sorry if I interrupt you for the question.
No, don't worry. Thank you. Just to conclude this brief case, it was just a case in which we provide some insights on how important is not just to evaluate a teaching hospital about hospital phases, because if we probably try to understand the mortality, 30-day mortality of our vascular surgeon here in Pisa, maybe we will have a fantastic green dots in our summary, in the outcome evaluation we saw before. But the problem is that if at the same time we have 5 times higher the probability of receive vasculation in our region, there's something that is not working. In this sense, we would like just to send a message that it's quite important to integrate evaluation of the hospital phases, especially for teaching hospital, but trying always to integrate this evaluation with indicators calculated for the population that these university hospitals should serve, even if they have not a precise catchment area. As we said at the beginning, in Italy, the local health authorities are in charge of organizing the healthcare services for their population, and the teaching hospital are autonomous organization. But even there is this organizational boundaries, teaching hospital should be somehow evaluated also with a population-based perspective, and in this sense, performance evaluation is essential, because what we measure is what the hospital will is what the hospital will take care and focus on. So, for example, to reduce the PISA, we saw an incredible reduction of the diabetic foot amputation rate in PISA during these years, and this is because the head of the diabetic foot clinics in the teaching hospital starts to work with the nurses in the community care hired by the local health authority of Pisa, and then we assign to the CEO of the university hospital the objective a target to reduce the diabetes foot of the local authority of Pisa. We try to integrate the targets and the objectives and the goals of
Can you hear us? We lost connection with you.
In 2 minutes, no more. I would just tell you.
Wait a second. We lost the last minutes because the line went off. So we saw the picture, but we didn't hear you at all.
Okay. Okay. Can you hear me now?
Yes, we hear you very well.
Okay.
yeah, I was just saying that in order to conclude this case, this was a case in which we try to show how it is important to evaluate the teaching hospital, not just about internal phases, but also considering a population-based perspective. I was saying just a paradox. If we calculate probably the 30-day mortality of our vascular surgeons here in Pisa, we will probably have green dots in our outcome evaluation, in the summary of the outcome evaluation we saw before. But it is a paradox if we have fantastic results in the hospital phase, whereas there are in the same area 5 times higher probability of receiving a vascular operation, lack of integration. In this sense, the case studies tell how we try to integrate the teaching hospital evaluation, to exploit the performance evaluation as a tool to improve, to enhance the integration of the teaching hospital evaluation with a population-based perspective. And in particular, we assign to the teaching hospital of Pisa the same target of reduction of the amputation rate that we usually give us and assign to the local authority of Pisa, just to make clear that the target of reducing the amputation rate in the population of Pisa is a joint responsibility of authority, but also of the provider, that is in the university hospital, that has not a precise catchment area of population because it is an autonomous organization. But since it is in Pisa, with a population perspective, it should be accountable for the overall result for the Pisa population. And this is what the case studies tell in the paper I mentioned before. And okay, about the importance of integrate the hospital care evaluation with evaluation that goes beyond the organizational boundaries, even and especially for teaching hospitals that are in charge of educating the next generation of physicians, and so they should be the first hospital that embrace this kind of perspective.
Margot was mentioning targets. In order to show you how Tuscany region, this region, is basically integrated teaching hospital performance evaluation, integrating it to performance management tools. And I just wanted to show you the target system in Tuscany, 2017.
Can I ask only one question? Hello?
Hey,
yes. Can I ask a question? We have here two persons from the quality office of our university. So,
Yes.
we would like to understand, when you talk about performance and all these things, what the quality office or quality department in university like ours, which indicators should they follow and be aware of?
Very good question. Now, let's say, we can say that there are two main perspectives to be followed. Try to improve the quality system and monitoring of their university. A lot of much more in detail they can about hospital care, hospital research, and possibly hospital education. And this is what we try to do also here in Italy by sharing with regions with which we work each year, new indicators to be added to our performance and evaluation system about hospital care and research activity. But, and so this is the first perspective. On the other side, we suggest that, especially considering the kind of system that we are trying to put in place and trying to shift from a treatment perspective to a prevention perspective, that the university, especially when we are in charge of hospital and primary care, to include those indicators on a population-based perspective. So try to understand how hospital care is somehow can use indicators at the hospital care as proxy to understand how the prevention is working. As we saw in the diabetic food case, the diabetic food amputation rate is an indicator calculated with the hospital flow, but it tells us a lot of how the integration between all the care carers. So in this sense, the second perspective is try to use the data of hospitals also to understand and improve integration with the other care services.
Okay. I would like to ask our representatives from Quality Office what data flow they are using to evaluate quality in AMP. Alexei, can you translate for them the question?
Again, what?
See that from the speakers say that it's the quality in university hospital should university hospital should check different data flows. Mm-hmm. So DRG or other things. So I'm asking, what type of data are they actually checking? Which flows of data are they actually using to understand the quality within this university?
Какие данные вы проверяете для изучения количественного качества университета? То есть вот для оценки качества в этом университете. То есть какими данными вы работаете?
Качество преподавателей?
Всего all the quality, like any kind of.
No, but she's from quality department?
Clinical.
No, not clinical. No, I'm saying from quality. Because clinical, yes.
Not quality of care.
Yes, we have clinical, we have two. It's, first of all, it's divided into one is clinical, and she's come from it, and the other one is from quality department.
Okay, so we're talking
so it's just both of them. Okay.
Okay. Вы не в курсе?
What do you mean?
Почему вы не в курсе?
Which data do you use for assessing the quality?
Как? Подождите. Еще раз.
I'm saying how they do their job. I'm asking them.
Okay, they just came there, so they didn't work on this data on their own, so they just knew by the, so.
Yes,
no
but you are
experience.
not new in your job. In your job activity, what type of data do you use to assess quality? Can you translate here, Alexei?
They understood the question.
Alexei, can you translate it again? My question.
Okay.
See, they are assessing quality.
Yeah.
To assess quality, you need data. What data do they use to assess the quality? Qualche secondo che abbiamo stiamo cercando di fare un match tra i dati, quello che fanno, che abbiamo partecipato alla qualità e uno per misurare la parte clinica, quindi stiamo cercando di capire quali database utilizza e quali fonti hanno.
Capito? No, perfetto.
So,
Количество ПП, владеющих английским
Нет, какие вопросы Okay, what they said. If they need to make, for example, a questionnaire for
excuse me.
one department, ask them to make some questionnaire. So it sends them questions. They distribute these questions, then collecting the data. But what particular information in these questions we haven't got yet.
So now the question is, this is a survey. So they are doing a job for somebody else.
Yeah.
What is the systematic way to check the quality in this university? There should be a systematic activity. I'm not asking what they measure. What do you measure in the quality department?
Что оценить?
So, do we have an answer?
We don't have an answer.
So, they do not do systematic analysis of quality.
Вы проводите анализ по поводу да, по каким критериям? Okay, usually you just question good, bad, where, what, like what cátedra, what department. Good,
So
bad.
only about education,
Yeah.
and they ask to the students.
Yes. Everyone, like
So
teachers.
my question is, their office developed the strategic plan of the university.
Yeah.
On what is based if they only ask if they like or not the lessons? Abbiamo qualche problema tecnico, ma darci un secondo. Però penso che sia importante anche per voi capire a che livelli che ci siamo qua, così come magari se domani collaborando sappiamo dove il punto partire.
Okay,
Sono assolutamente coinvolti.
Okay, usually Ministry of Health sends them some indicators, and they're doing their plan with in accordance with only with the indicators from Ministry. So what Ministry will send? What indicators they will
So they only measure the indicators from the Ministry sent them.
No.
No, wait.
Can I tell, please?
You are from a different university.
No, a different university, but the system is the same.
Yes, but I want to hear from them. It's their job. It's their job. If I ask her, she will answer me. So I want to ask them that is doing this job what they are doing. So we understand here how it's working, because we have to change this university, not another university. I'm not wasting time. It's very important. So, Alexei, can you translate this question?
Okay.
How can you develop the strategic plan if you don't use data?
Как вы можете разрабатывать стратегический план, если вы не используете данные?
Okay, let's ask somebody else. Which type of data do you use to analyze from the clinical point of view? Yeah, what data do you use?
Данные по количеству категорированных врачей на клинических кафедрах. То есть у нас есть теоретические количества, берем количество клинических кафедр по отношению к общему.
Так, а вот теперь еще раз и помедленнее переводить.
Так, в общем, у нас получается есть клинические кафедры.
Okay, they have clinical categories and theoretical categories.
Количество клинических кафедр.
Wait a second, Alexei, can you come here so they listen to? Otherwise they are like
Okay.
So it's you talk. He will translate from Russian. Huh?
Клинические кафедры, их специфика, что там работают, помимо как выполняется дополнительная функция, это клиническая
Okay,
деятельность.
here they have two types of categories, clinical and theoretical. The difference is that on clinical categories there is additional types of activities, is like clinical activity in the university. So
Поэтому основной показатель, который мы курируем, это категорированность ППС на клинических кафедрах. Категория. Категория, то есть есть понятие квалификации.
Okay, so the main indicator they are using is the qualification of the qualification of the staff doing this clinical activity.
В общем, профессор-преподавательский состав как врачи.
Yes.
Врачи у нас имеют понятие, может быть, просто иметь сертификат специалиста без категории и делятся на вторую категорию, первую категорию, высшую категорию. То есть в зависимости от стажа. Чем выше категория, соответственно, тем выше считается специалист, уровень специалиста.
Okay, so here, for example, doctor can have just a certificate that he's a doctor. Then there are three categories of qualification, like addition, like second, first, and the highest. This level you can get. You're getting this level based on your experience in this sphere, and so they pass in exams.
Наличие сертификатов прохождения курсов обучения.
Вот эту часть еще раз и громче, пожалуйста.
Категория зависит не только от стажа,
Да.
но и от того, сколько часов где он проучился по специальности.
Потом сдача экзаменов.
Okay, this qualification depends on experience, passing exams, hours you work, hours of additional education to raise your qualification. So that's the main indicator for them analyzing like.
So, but you are clinical. You monitor the clinical activity.
Yes.
This is human resources. This is human resources Do you have this certificate? Do you have this permission? This is your level. This is human resources job. Clinical means that I touch patient and I need to have results on patient. As we see today, mortality, complications, how fast you treat them, turnover on the beds, blah, 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 blah. You don't monitor anything about this.
Нет.
No.
No.
Потому что нету клиники.
Okay.
А данные,
But
You monitor how many hours of
мы, у нас есть данные, какой объем проводится консультаций, манипуляций, операций.
yes. But I want to show that all this is collected on serious.
Нет, это нет.
No? No. So it's not collected on serious. So it's on paper. So that means that we don't have an information system about this. I can write whatever I want and nobody can say yes or no. It can be totally not connected with reality. Is that correct? And nobody can verify what is written over there. It's not transparent. Okay. So,
Wait.
but one thing.
I asked it without.
So the point is, at the moment, so at the moment, the reality is that we don't measure clinical activity. That's the truth. The point is that we have an excuse. The hospital is not ours. But still, we only have that students perform 5 manipulation or 10 manipulation because it's written on a paper. But it is only written on a paper, so we not even make statistics. We cannot cross the data to see if actually he's working the same week 48 hours on manipulation, 48 hours on studying, 48 hours on research. That makes 3 weeks in 1 week, because we cannot cross the data because everything is on paper. So we are highlighting a very critical point. Nobody is actually measuring quality. That's the reality. Not quality on education, not quality on clinical activity. They are just collecting some surveys and they are collecting papers as human resources. So this type of activity in Italy and other countries are run for staff from human resources and for students from the office that follows students. But they are not quality or not. The main critical area is if we don't have data, how are we deciding what to do with our strategic plan? Is our strategic plan any connected with reality? So, if tomorrow the Ministry of Health is giving us, as we requested as university, 2 hospitals and 7 ambulatory polyclinics in the district level, who will monitor all these indicators that from Italy are explained to us? Nobody. We do not have office for this. We have nobody with experience to do this. And this is very, very important, because if we do not start to prepare for this, we will crash. Because we will have to analyze for all these hospitals economical balance, economical expenditure, like they explained this morning, clinical activity, outcomes, output. Who will do this? Now you understand why we are talking about creating 5 offices and 2 of them separately from any other office will work on data collection or maybe data creation, because we don't have any flow of information, and business intelligence, because this, what they are presenting, is the job of business intelligence. When I suggest to create these 2 offices, they say, but we have the quality of department. I say, which one? Oh, we have 2. So that's why I asked the question. And then I said, we need another one to create a strategic development. so that they can actually write our strategy and our strategic plan. And they say, well, we have 2 quality officers. So I'm asking you how you are doing the job. Because if this is the reality, then we need other office to do this job. And move this office under human resources. Or empowering this office with other figures that can do this job. Otherwise, we are just answering, as Professor Brusetti was saying today, check, check. Yes, they ask, we answer. They ask a question, we answer something that it doesn't really match, but that nobody will read it in the ministry anyway. But something is different. This minister will read it. So we cannot write as before. We have to change what we are writing. I have to be connected with data and reality. It's not like a poem. It's reality. That's why it's different. Okay? So see that this office are coming out from these people. I want you to pay a lot of attention to this type of lecture, because they're very important, because some of you will call Italy every day to ask more details. And I hope that Italy will answer from Pisa.
Yeah.
Okay, maybe we can write a memorandum of agreement for a long-term collaboration.
Yeah, why not?
So,
Why not?
this is why I'm focusing on that. Because we all know it, but we have to put reality in front of our eyes and understand what we want to do. We want to just make poems for the ministry, or we want to do what the minister says. It's a choice. As we say with Professor Brusetti today, we can say, we will be here when the ministry will go. The new minister will come. That's what it's a strategy. Another strategy is we comply to the minister. Then we have to move. Otherwise, we are not in the same line. So I ask you, even if it's lunchtime, after lunch, and you're very tired, and I will show you some picture I took during the lecture of people sleeping and closing their eyes, or keeping their eyes very wide open, to keep your eyes open and be concentrating, especially if you want to be in these 2 departments. And I really hope that somebody of you will be in this department. Otherwise, we have to start everything from the beginning with somebody else. Because nobody, not only in this university, nobody in Kazakhstan, in public system, in the health system, do this. And I think you all agree about this. So, I'm sorry for this interruption, but it was a way of keeping everybody awake. You can go ahead.
Yeah, thank you very much. Just, I completely agree about what you were saying. There's an old quotation stating that if you cannot measure it, you cannot manage it. And I always recall this quotation. And actually, the region we live in Tuscany, strongly believes in this quotation. So they strongly use performance evaluation system in order to steer, to manage how the local health authorities and how the teaching hospitals behave. And I just wanted to show you the 2017 target system. The target system is a law that was issued 7 days ago, and this law basically states all the targets, all the goals for each health authority. So it collects indicators and it puts targets on each indicator. So basically, the regional administration defines the goals for each local health authority, both local health authorities and teaching hospitals, and of course each health authorities then through the budgeting system basically trickles down those goals on their organizational units. And basically, the 2017 target system was made of some preconditions and some targets. Regarding the preconditions, basically, each local health authority, each hospital, teaching hospital, has some precondition in order to achieve those goals, and so in order for the CEO to get the financial incentive. And basically the precondition were financial stability, compliance to national standards regarding service provision, some indicators about investments, so containing investments, and the fourth precondition was about volumes. But I was interested in showing you targets, because 40% of those targets related to those very indicators Tommaso shown to you before. So basically, those targets are threefold. Basically, those targets assigned to teaching hospital are of three different kinds. So we have some targets that relate to hospital-related indicators. For instance, in this case, you can see that each teaching hospital needs to achieve at least 80% of net thermofractures operated within 2 days. So during 2017, each teaching hospital needs to achieve this goal. And these are typically hospital-related indicators. They are indicators that relate to an activity actually performed within the boundaries of the teaching hospital. Okay. Secondly, we have different kind of indicators. They are hospital-related indicators, but they have a specific target. So in the first kind, I go back. The target was 80% for each teaching hospital. Second kind of targets are targets that are hospital related. In this case is C-section deliveries, but as you can see, teaching hospital has a different target. So it is 19.36% for the teaching hospital in Pisa. It's 19.03 for the teaching hospital in Siena, and it's 17.63 for the teaching hospital in Firenze, Careggi. This is because those indicators are relating to the baseline, to their starting point. But I was more interested in showing you the third kind of indicators, and those are the indicators Tommaso was mentioning before. So, teaching hospitals are assigned some goals that do not specifically refer to their activity. In this case, for instance, this indicator is the standardized hospitalization rate. Okay, these indicators do not refer to something the teaching hospital has a straightforward responsibility on, but they are called for a shared responsibility with all the other actors in the system. Is that clear?
Yes.
We already published last year or the year before about the difference between assigning a fixed goal or a customized goal to each health authority. Now probably we will need to publish something about assigning to teaching hospital a goal shared with other authorities. So if you want to publish with us, to research with us about this topic, we will be more than happy to cooperate with you. So basically, we will need you some key references about something we have published regarding the topics we have dealt today. So basically we have tried to give you a wider review about what we do and what we are going to do about teaching hospital evaluation. We hope that in some way we have kind of transferred and shared with you something of interest for you. So we really thank you very much about this moment, and of course I leave the floor for any other queries or comments or whatever.
I want to thank you for your lecture, and I think it was very, very good. And we thank you very much for your explanation, and sorry if we ask so many questions. And I think it's important that we understand that the level of focus and details that we have in Italy at the moment here in Kazakhstan is not present, and that we have to work a lot to start this process, because we want to be the head of this process. We want to be in the front line to show the minister that it's possible to do it. And I think it's very, very important, because especially because we don't have hospitals, we can focus on monitoring other hospitals. So our role is not out to monitor ourselves, but to sell ourselves as monitor of the other system, of the entire system. So I think the collaboration with you would be very useful if we have in our ideas to start this process to analyze all the other hospitals, maybe starting from regional hospitals, city hospitals, and propose this way of measuring. That is what the ministry is looking for. So, and we can learn from you a lot and about this type of topics and how to use the data flow that at the moment are absent in our system, but we can ask through memorandum of agreement to share, ask other hospitals to share the database so that we can analyze it and give feedback and resell our expertise at the ministry level and to the other hospitals. So instead of investing in hospital that we understand that we are not able today to monitor, we can invest in learning how to monitor and resell this knowledge to other hospitals and other universities and to the ministry level. So I want to thank you very much from myself and from the AMO University, and I hope that we will soon start organizing maybe a memorandum of agreement, and maybe we can send our example of memorandum of agreement to you so we can see if it matches, so we can proceed and maybe organize something in the future.
Sure. Thank you very much again for your taking, and have a nice afternoon and have a nice summer school.
Thank you very much.
Thank you very much.
We will put your emails and contact on guidebook for everybody, so they can feel free to write an email if they have doubt or not on the materials. Thank you very much again. Bye bye.
Bye.
So yes, now it's break time, but it's also debriefing time. What is debriefing and break? Again, was asking me. Means that we relax, but we still thinking of what we were exposed today. So you just relax on your seat, breathe, and we start a discussion on what we need. This is the first step that we will find later in our summer school on strategy development. So please relax, take a big breath, and let's start to think. Because Yermek is here, and we were discussing now about how do we measure quality at the clinical level, at the university level. And yes, and we understand actually, while from Italy, they were explaining like performance indicator, like how much it costs to work how much it costs a procedure, or how much time does it take to do a procedure, the quality, the mortality, the revenue, the case mix, to understand how difficult are these patients. We asked to our two offices, clinical offices, how do they measure it? And actually we understand that there is no data. The quality department say that they do not have, they do not watch data. And this is critical because then we don't have quality. It makes like survey. But this is occasional. It's not a systematic way. And the clinical department for quality do not have data on clinical activity. They have, if a doctor have 1 or 2 or 3 third level, if they have certification, but okay. So what is important? I want to talk with you to debrief. Debrief means that we analyze what we heard. I think what is important that we rethink on what all the information came in our mind. Our mind is very full now. So I want you to understand in which direction shall we go. Because at the end we have to write our strategic development plan. And our strategy first, that is different from a strategic plan. So now I give you the word and you can ask, you can say whatever you want. I'm sorry that I interrupted you before.
Can I sit, yes?
Yeah?
Can I sit and yes?
You can tell.
Yes. So about strategic development. For example, in our university in Sevilla, we also have such department of quality system management, yes? And there are one strategic document which are divided by some process, for example, scientific process, clinical process, educational process, and we have some departments, yes, which is gathered some information, yes, indicators. We measure it really every year.
You are telling me that you are decentralizing the monitoring.
Yes, we can.
But we cannot decentralize too much.
Yes.
What is happening here? What is happening here? It's very important. Please listen. The ministry. I was talking. I have to review a precast on emergency system in Kazakhstan. So I had to review a precast. So they say, look, you have to visit a patient within 10 minutes on the precast. But there is not written on the precast who should monitor it.
Yes.
So they say, well, regional office will measure it. Then you talk with the regional office, say, no, we do not measure. The hospital will measure it. Then you go to the hospital and they say, no, department will monitor it. And then when you go to the department, say, INUR is monitoring by some vacation. So, but it is important that INUR writes 10 minutes so everybody's happy. When you ask INUR, how do you measure 10 minutes? You say, because they write 10 minutes here. That is the correct way. They say 10 minutes, so I write 10 minutes. So when we write a strategic plan with no data, it means that the ministry says, I want A within 3 years. So the university say, we will do it in 3 years. And then nobody monitors. We do it, we don't do it, who cares? Sometimes the ministry wakes up and say, are you doing it? Of course. Here, write the paper. We are doing it. See, we are doing it. This is not how to run a university hospital, okay? This is not planning. This is answering what the chief wants to hear. It's complying. You just say, okay, we will do it, yes. Okay? That is not good. It's better not to answer or say no. At least we measure it. We don't know how to measure it. We didn't measure it. It's better. At least you have a feedback, a real one. This way, it's nothing. So, but we have audit systems to control, internal audit system to control it. Anur is saying 10 minutes and controlling that this is true. How do they control? They read the paper. That's not a control. It's all about papers, certifications, paper, certification, and then nobody trusted certification. So what we want to build, it's a different system. That's why we are creating offices that do not exist, like data management. How can we run a university without data? We don't know where we are going. It's like if I'm driving the car with a black blanket on my windshield, I cover all the dashboard and I just move around. So it's very important that we base our decision to data. And if there is no data, the decision is to make data, to find data. Because otherwise, you risk to make huge mistakes. If you are not able to measure your people today, that is very simple. Today, the university have a very simple environment. It's like if you go to English school. They have teachers and students. Very easy. Clinical activity, they go somewhere, but they don't do anything. So it's actually easy. Okay? And you are requesting to the ministry to give you 2 hospitals and 7 polyclinics? Are you ready for it? Because the risk is that you lose so much money in the first 3 years that you close the university, and other university will take this place. And we fuse AMU with ENU, with Agricultural University, with Nazarbayev. Somebody will eat us. He will take this building that is not a hospital and transform to laboratory for agronomy. It's just in front of our school. You just cross the street. So all of you lose the jobs. It is what you want. Because this is what will happen. When people talk about autonomy, it means you will walk with your foot. And if you do not walk, you sit down and find another job. That's autonomy. It's not I will pay and you do whatever you want. It's not like a 17-year-old boy that want to go to the disco. I want autonomy. I want to go to the disco and the parents pays. No, that's not autonomy. Autonomy means that you get your money, you go to work all week, you get your money, you go there. If you make a mistake because you get drunk, you pay the consequences. So autonomy, if it's not properly organized and it doesn't have unlimited funds, means that you will drown. And Kazakhstan, especially this university, can drown easily. Why? Because there are already a lot of universities producing a lot of medical students and a lot of doctors. We have too many doctors, so we should shut down some university, medical university. And Astana have 2 universities. There is Nazarbayev and Astana Medical University. So why don't we shut down one and give this building to the next door? Agronomy. It's easier. It's much easier. Don't you think that anybody have already thought about this? It's easy. Oh, they were not profitable. We close it. We cut 800 new doctors, but we don't need them. Astana do not have university, medical university? Yes, it does. It's wonderful. It's a huge, big block of Nazarbayev universities. It's there. So you will not exist in 3 years. When Nazarbayev has 6 years, 7 years, this university will shut down. Only if you start to work properly, you survive. So I'm here to make, like when people is throwing, I'm your lifeguard. I'm coming to pick you up and bring you to the land. This is the reality. So the plan is, let's do things, let's do it quickly. If the option of today, it's wonderful, the one of Luca, but needs 6 years of culture development, it's too late. We'll be closed for that period. Maybe yes, maybe no, maybe it's different, but the chance is there. So the point is that I'm here because we want to be in the top of university, not to be close, I'm sorry. Okay? So our job is to define what we want and which is the good market to go. In Kazakhstan, 1 day in the hospital. How much it costs 1 day in the hospital? I say, I go to the hospital, any hospital, I say, I want to stay here for 1 day. But you know what? I don't want to, like one of the hospitals, city hospital. I want to go to the best hospital, the most expensive one. I will go to Nazarbayev. To Nazarbayev hospitals, and how much it costs? How much it costs 1 day to stay in the hospital?
It depends on nosology.
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 Are you sure?
Yes, I'm sure.
I'm not as sure. I'm not as sure because I've been running hospital. The price the same. If I get a surgery or nothing, the price is pretty much the same. Because it's like a hotel. You got a room. It doesn't matter why you are in Astana. You got a room. So it doesn't matter why you are in hospital. There are slight difference, a small difference, like a few. But how much is mean average of the price of staying in hospital?
About 15,000.
15,000 per day. 15,000 in euro is 30 euros, 40 euros. With this money, can you pay the technology that you are buying or to maintain the technologies? The answer is no, because the price to maintain a technology, to buy technology, is the same as in Italy. In Italy, it is based on DRG, so if I am some type of patient, I will get more money or less money, then usually it's more than 1,000 euro. Because you have to pay the cleaning lady, you have to pay the nurse, the doctor, different doctor for different times when you are inside, night and day. You have to pay the electricity, the gas, blah, blah, the technology, blah, blah, blah. So, if I buy a technology, ultrasound, focus ultrasound machine, cost 1 million of euros, when the hospital will be able to pay it from its revenue? Never. Never. So you get a hospital, you buy a lot of machines that nobody knows how to use it, and you collapse. And you close yourself. And you sell the machine. So the question is this a good choice in this moment? Because we wrote in the strategic plan that we want 2 hospitals and 7 clinics. Is what we want next year. We want it only if we know how to run it. Why we chose network of polyclinics, ambulatory settings? Because it's cheaper. I don't have big technologies. I just need a lot of people, a lot of doctors to check people for easy sickness. But we have a lot of young doctors that don't have the chance to see a patient. Why don't we take this and put it with the patient? It's 0 cost. But if we open a high specialized hospital with heart surgery, with neurosurgery, we will collapse because our doctors are not able to run it, because we prepare general doctors. We have to remember what we produce. We produce 800 students with basic knowledge. We don't have high specialists. So I have to buy specialists from abroad or from other cities in Kazakhstan, pay them a lot of money, buy technology, and getting 30 euros at the end of the day. It's impossible. If I call here a good surgeon from Russia, from Italy, but also from CIME, can I give him 30 euros? No, I cannot give him 30 euros because with 30 euros I have to pay the nurse, I have to pay the cleaning lady, I have to pay the maintenance of the instruments, the loan that they bought. So will he come here for 5 hours to work, to make an operation? No. So I have to pay more, and so I will not be profitable. I will lose money. So, or the minister today gives you the money to say, okay, who cares? I give you money, doesn't matter if you're not profitable, it's Kazakh people, go ahead. But if in his mind he asks, are you profitable? You're dead. And we are not a no-profit organization like Asfendiaro. We are for profit. So the main question is, if you make money. Now we lost 3 billion of tenge. Oh, very good. You have to remember in which boat you are. You are in a joint stock company for profit. Or you have to change, or this is your type of animal. Okay? We have wings, as we say the other days. We have a lot of opportunities because we have a lot of freedom, but we walk like chickens. And then a fox comes or a wolf comes and eats us because we are easy prey and we cannot defend ourselves. So the real point is we have to define what's wrong. What?
Well, chickens.
Chickens. Yes, but it's the reality. That's what we're doing. We have the most. You were talking the other days about special laws. We have the most powerful special law because we are in the market. We are free. We are really autonomous. We saw every time I say we can change the programs, they say no, Minister of Education say that we cannot change. And then we check the law and say that we can change our subject freely, especially us. We can create startups because we can do. Asfendiarov cannot do it. So we have the most powerful weapons, but we don't know it. And we just walk around like this. Asfendiarov cannot create a startup with this law, a startup to create our research center. Cannot. It's very difficult. We can tomorrow. We don't have to change the laws. Okay? So it's very, very important. So I want you to start to think now, we are in the second week, about what are we going to suggest to the rector to do to survive. What we will do to be the best University of Kazakhstan, so that we can export our model to all the other universities. So I want you to start thinking, getting information during this lecture, to write down your strategic plan. Because this is what I will ask you in few days. I will ask, what are your ideas for the strategic plan? You have been watching project. You have been watching economical point of view. We ask to departments. That's why, see, I put in the program, question and answer. And nobody understands what was it. What is it? That we call the departments and ask, what are you doing? Because if you are doing correctly, then it's fine. If it's not, we will write that you have to do this. So are our legal departments aware of startup legislation incubators? Because that's the path. The ministries are asking them. Do they have ideas on somebody here about autonomy? Do we have ideas? Do we measure ourselves? How do we measure ourselves? So I want from you to start thinking what we shall write on our strategic plan. But before writing strategic plan, we must write a strategy. What we want to do. So the sequence is what we will be, what we want to do, our strategy, how we want to play, defense or offense. Then if we decide to play in offense, then we decide to put 6 players trying to attack the others. If we want to play defense, then we will put 1 because everybody is playing on defense. So strategy is not about things, it's just what we want to do. We want to work as a private, we want to work as a holding, we want to work as a non-profit. It's general. What do we want to do? Keep the system like this. Second step is strategy, strategic development. So we write the strategic plan. Strategic plan. When we write a strategic plan, we go in details. But then we have to write the what I've shown you the other days, the roadmap. The roadmap will tell exactly who has to do it, what, in which deadline. It's a Gantt. Somebody will watch that we are doing it, and then we check the results, and we bring it back to our strategy. So these offices are working as a team. Somebody of you said, but I like some subject, but I don't like the other subject. But the point is that you have to be aware of all this information. Then you will specify in 1 or 2 main area. But you have to know what the other is doing. We cannot work in silos, not knowing what the other are doing. This is very important. Very important. And when we have information, they have to be true. It doesn't matter if they're ugly, they're very bad. They have to be true. That's why one of the things is to organize a system that works on truth. I ask you a question, you answer, and you put your signature. If that answer is not real, you lose the job. It's called certification. I certify that this is true. I know to write 10 because the minister expects 10 in the previous example. If 10 is not there, he goes to do the taxi driver. That's how it works. Of course, it's very difficult. Environment, lobby, just inertia from the system. So the main idea is if you want to do it or you don't want to do it. You need to be under the rain, bad days, fog. But this is what the minister is asking us. To change this university. Not for me, not for him, not for the rector, not for you. For Kazakh people. And he's taking a lot of money to do this. I was here in the other room talking with Yermek. Yermek said one very important thing. It changed my mind completely. And he's not always there when you work as a consultant from abroad. A lot of people come, talk, get the money, go away. Especially if they're retired. If they are old. Who cares? I have to go to the seaside. He told me, The ministry is getting so much money from the World Bank that our future generation will pay. Your son, even if you don't have one today, your daughters will pay. And we are wasting all this money about blah, blah, blah. Then don't take the money. We stop and we keep going. Because you will pay. You will be having small salaries, less service, because you have to pay back the bank. It's like taking a loan and go to the casino. Or drinking with the girls in nightclubs. Okay? So I'm not like this. And I promise HTAcamp that we would do our job. We can fail, the system can stop us, but we tried. So this is what we do. And to do this, we need people that are motivated, that are young, that are not involved in the system. There were a very smart girl from this university, and she wanted to apply. And I said, will you be able to go to one of your professors, or to your professor, because she was a PhD, and tell him you did a bad job, you have to improve, otherwise you will be cut out and you will lose your job. He said, oh, they were going to kill me. So maybe you should think about it to get this place. Because that's what we will do. That's why it's important people from CMA, from Nazarbayev, because they don't care. They don't care to go to a professor from Amman and say, you did a bad job. No, not because I think so, because internationally you are doing a bad job. If we compare you with the rest of the world, it's very bad. Do you feel like doing it? Because if you feel like doing it, then you are welcome in the team. Okay? That's why I'm talking to you. That's why we are deciding this. It's not easy. It's not easy at all. It's very difficult. Katie and Beatrice are working with me in Italy. They know how tough it is. How many enemies you get.
If they're interested to work in the team, they will not be afraid to say to the professor they're wrong, right? So I think it's not about where are they from, which city. It's about interest. If they're interested, they will say that.
Yes, of course. I'm not saying that I'm not taking people from Amman. I'm saying that you have to think, if you are so much involved, if your uncle, your father, your mother, your grandfather is working here, maybe you're not so independent thinker. So I'm not saying no, but that's a job. And I will push you to do this job. And if you have resistance from one side, you will squeeze in the middle. So think about it before you apply, because this is the type of job. Of course, it's not you or you or you. Some will be in the front line, somebody in the back line, but it's an army. Somebody will get the data and pass the army in the front. Somebody will analyze, making better weapons, and then we go to the front line with very strong and powerful weapons, where nobody can say yes or no. When we calculate the data in Italy, most of the Italian people, of doctors, say, no, this data is not true. I have my own data. So, my own data means I write whatever I want. It's 10. Okay, 10. I'm 10. Because I'm 10. No, this guy died, but he was not nice. The other guy died, but he was old. So we don't count them. So the other guy died. Yeah, okay, but a lot of people is dying here. Okay? So maybe we should evaluate that. Okay? From our, I'm not against anybody. I just want to show the truth. Because when we start to see the truth, people start to go back to what they should do. What they are paid for. That's our job. Because your government is paying these people to do a job, and maybe they're doing bad. So I don't want to say no, we don't want to, but we have to help them to go back in track, to do their job. That's our job. And when we went in Italy, we did this. We said, no, we believe what the government sees from data. You want to change data? Write them better, day after day. Do it with yourself. Not at the end of the year you just write 10. Do it during the day, every day. Plan. So in the beginning, of course, there is some tensions. But the good ones are happy. The ones that are not good, they know it. And they are a bit afraid. But there is the point. The point is that we are not there to hit them. We are there to support them to be better. So when we go out from this university, we can compare with the others and say, we are better. Because we are more transparent, we are internationally benchmarked. That is what the minister is asking, not me, because I like it. We can really show our data. So, for example, I spoke, everybody is asking, we want our university to be in the ranking of the university. So I wrote who's doing the ranking. I say, hello, we want to be involved. I said, we are very happy. Please fill up this form. So I come here and say, we should fill up this form. So they will include us in the ranking. I say, but we already filled it up. Really? Yes, but we answer only 3 questions over 25. So they rejected. If all the other universities are more than 25 indicators, why don't we have any information about it? Who is responsible then? So actually what we are doing is taking the university on your shoulder and running ahead of the others to win the race. What I can promise from my experience, they do not have the time to shoot us. Because people, to organize to shoot you, it takes around 3 years. For that time we are living, right? So nobody will have time to shoot you. It's evidence-based. We have done it more than once, so we know that they take time to organize. Lobby and pressure, political power, 3 years. Because they are slow. If we act within the first 6 months, first 12 months, we win the race. We arrived, the game is stopped, and they didn't move yet. Because they are slow, they are not organized. Okay? So we have a lecture about just culture next week. A professor is teaching that. I want to put some culture in you as well. Did you ever read a book? This is the most read book in the world after the Bible. So it should be like after religious books is like the next one. It's called From Dictatorship to Democracy. Okay? And he explained how you should subvert dictatorship. I'm not interested in subverting dictatorship, but we have to understand what are our blocks in this job. Our block in these jobs is people that says, yes, I will do it for you, and then don't do it. And then when you go back, they say, don't worry, I will do it, and then they don't do it. Then you go back again and say, yes, don't worry, I will do it, I'm working on it, and then don't do it. That's why we create 5 offices that are totally independent. They take the job on themselves and run out of the track. Okay? So, this is a sort of debriefing, and because it's one way, but I think it was important from this point of view. Because if tomorrow somebody will not be here, I understand it. But it's correct. You could tell me before. I spent here 4 weeks, and you tell me the last day. No, I'm telling you now. I'm telling you now that this is the game. So think about it overnight. Think if you really want to do it. But I will, excuse me. But I will tell you one thing. If boss, very high boss, wants this, all of them. They don't know how to do it, but they want it. So if you learn how to do it, you will find a very good job with a big salary. Because nobody knows how to do it. Do you think there are a lot of people here knowing how to do it? I don't think so. The only one that maybe are good at it, they go in the private system. They go for oil companies, smoking company, blah, 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 car renting, car selling, apartments. They're not working for the government. The salary is too low. That's why here we have all young people. Some of the people came in the store and look at you. And they ask me, why are you teaching them? Why are you doing this seminar? They are so young, you don't need them. I said, I need only them. Who will put his shirt on, work in the computer all day for 1 month, being here, understanding new things, totally new. I see your face when we are talking. I say, wow, what is this? Okay? I say, I'm learning it. I will learn more and I will put in practice. Only a young, motivated, good professional. That's what I'm looking for. I'm looking for you. You're not too young. Okay? So, but you should be highly motivated because the job is a lot. So this is a survival camp. Somebody's falling asleep, and we know who is it, but somebody's like dying, drinking tea all the time, just empty the tea tank. It's a survival camp. Why? Because you are being prepared to survive when we go on the jungle. Okay? So, let's start the briefing. This was the break. So, what do you think? What are you afraid of?
Questions.
Sorry? Lack of experience. You make experience only on being in the jungle, not thinking about the jungle. So I'm offering you to go in the jungle in a protected way, because first they shoot me. So you are safe. Right?
I'm afraid of bureaucracy because I use the state university, and we're gonna face a lot of bureaucracy here. And the only thing that I don't like is like hierarchy.
Hierarchy.
Yeah.
Did you check the organigram, the organizational chart? It's in your Dropbox. Okay, where are you located? Are you sure? Are you really sure? Okay, let's open up. Let's see where we are. Where we are. That's a good question. So let's open Dropbox. Slide summer school, model 2, day 1, organizational chart. Is it there? Yes. So where we are. Where we are. Students. I'm not talking about students. I'm talking about the survival of this table. Where will be they located?
Among the department.
Okay. Can you see the left here?
Yes.
They are located there.
Left one.
Can you see all of them?
Yep.
So, from this one of these office, you go up to executive director. Who's that person? That person is me. Then you go up, and the next one is rector. How far are you? Not so far, actually, watching it. Huh? Not so far.
That's only the chart that we know. Like,
No. See? Here, this function is to tell other people what to do. And it's doing it thanks to this office, Management Control System office. These people analyzing all the data, they go to somebody and say, you have to do on your balance scorecard this. This is within February. This is within April. This is, if you don't make it, we have a problem. Okay? So are you sure? Or now you have doubts? So maybe the salary is not high, but the position is important. The experience is important because you will know how to do the job tomorrow. And who of you actually ran a team before? A real team.
In a classroom.
Yeah, a real team. 1, 2, what type of team was it? In classroom. No, not in classroom. Classroom is like a game, like an hour.
Football team does count?
Football team does not count. Because the leader is not the leader of the team, is the coach. Huh? Student society depends on the position. You were the president? Okay, president. Okay, this is. You?
A job being a team leader.
Team leader of what?
Actually, like organizing the process of work. Like I was, higher than me was supervisor, like manager, supervisor, like supervisor, manager, team leader, and all the other stuff. I was on the second chain. So
how many people were there? 5, 10?
20, 30.
See, so this is, so we have 2. All the other never ran a team. A real team, of course. I finished. I give it for granted. But the point is, you never run a team. I'm giving you the opportunity to run a team. To be responsible for a team. That means that you don't sleep at night. You work, rabot. And basta. So this is how it works. But when you create something, it's yours. You feel like you made like painting, like Van Gogh. You say, yeah, this is mine. It's ugly, but it's mine. Okay? So it's an opportunity. It doesn't come every day. Sometimes you get this opportunity when you are very old. Maybe you are 40, 45, 50. If you're in Italy where the people are, the mean average is 45, you need to be 60. So at the age of 20, you're 22, 25, 28, you have this opportunity, your mind will go like a corn, like a popcorn. So it'll be totally different. You get an experience you usually get only later in life. And this will change your life, for sure. Not me, just the situation. Okay? So, more questions? She looks like she's going to cry. I'm very sorry.
No, I'm not going to cry.
It's just like, I'm sorry. So, come, tell some questions. Ask. I know that you have one. You're watching the telephone just because you don't want to say it. Just tell me. Ask. You have it. When you're ready, you will ask. Come on. We are waiting for Just. It's finished at 8 o'clock. Really, we are waiting for Just. But he didn't answer, so he should arrive. See, okay. See, when you'll just let us know, is he coming?
Tomorrow, you don't have what time?
So, 6:12. Oljase, I just came out from the ministry. I hope he's coming. We are waiting for you.
It's crazy right now, so it will take some time for him to come.
4, 0. Huh? As soon as he's yeah, I want to give this. Yes, I want. Yes, but remember he said he wants to talk to me. Maybe we have 15 minutes to say, oh, let's talk. Yeah, whenever he wants. Okay? So, I like the attitude. She just said, oh no, oh no, oh no, oh no. But she's not leaving. She's not leaving. So please ask more questions.
How
Yes.
many people do you want to hire in total? Like, I'm not talking about the chief ones, but we're going to have 5 new hires.
Okay, we cannot create an office with one person.
Yeah, of course. That's
So
what-
minimum 2. The point is that I am trying to understand. I'm trying to understand if all of you are actually worthy to be employed. It's not because you were here then you get a place. So it's not a problem about number of places. If you worth it, you are in. We will make the space.
So if you'd like to gather.
See. Okay. Do you want it? Aperto. So it's not about places. We are renewing the system. Do you think they make a difference in the salary of one person? Especially in the lower level? No? So the question is, will you all be able to fit in? Because I cannot make an office of strategic development of 15 people. I don't need 15 people in strategic development. And then leave empty data management. So I think it would be useful from the next week if you just select one office. Maybe it's not your defined choice. But so we start to see how many people we have in one office and in the other office.
And how do you evaluate people involved?
First of all, they have to survive.
She
she understands exactly what I mean.
understood all of us.
You are here since 2 days. Huh? They did 10 days.
Yes, but
So
I
first of all, you have to
understood
survive.
what do you
Second things, you have to show that you can run the business. You have to run the office. That's why we are playing with the leaders. Last time she was a leader, now he's a leader, next week she will be a leader, and then she will be a leader. And people will say, oh, I like her as a leader. After a week, say, no, I will go to her. No. And then finally, after 4 weeks or 5 weeks, we will find the right leaders. And people will start to say, look, I select you, you select me, we are a team. And new teams will start to create. At the end of the process, we will have normally, easily, teams that are working together. Now it's like one big block. And then slowly will become fragmented. Office will come out. Then some office will go back and fuse with others. You remember yesterday groups? You were not keeping pace, fuse with a different group. And then different groups takes other people and rearrange. It's biological. It's Darwin. It's Darwin theory. That's why it's so long. It's so difficult. Because it's survival camp. It's very difficult. And you have to show. But it's not me evaluating you or her or she. You are evaluating each other. Because when I say, no, I don't want to work with her, not me, but I don't want to, and nobody wants to work with her, how can she be a leader? I don't get any influence from outside. I don't care who's sending here people. They have to survive. There are people, some people are so afraid they don't even arrive. Yes, I will send you 2 of my best players. Never arrived. I just need to talk to them on the phone. So, you are survivor, especially the one that made the first week. So I'm watching you all day, how you live here. Because we will work like this. We will sit all around the table and say, did you get data? No, why? Why not? What's the problem? So I will go and fix it. Then I want the data by tomorrow. I go to the chief of that department and say, I need data. And I fix the problem for you. I'm your problem solver. But you have to work on doing the data. You have to make statistics. I will help you. I don't remember how to make the join point. Can you explain us? Of course. We just sit here an hour and explain you. Then you can expand. You will look for, you're the chief, you look for adequate people, train them. We will go and look for students that want to have an experience, like her. Say, I want to have an experience, but I'm an intern, who cares? I was running an entire hospital. Okay, experience in Almaty. Director calls me and he says, I have this hospital. It's open, I renew it, all of it. I spend a lot of money. And I gave to one of the best managers, hospital managers in Kazakhstan. And this hospital is empty and he's losing a lot of money. Can you have a look? So I say, okay, but I cannot do it by myself. I will take a team. So I select from the classroom I was teaching to. They were last year students, just graduated, residents. And then I said, I want him, her, him, her, him. We went there. In a week, we analyzed the hospital. We showed the results. The rector said, okay, you are running the hospital. All the management go home. Big decision. What do you want in your team? The same people that made the assessment. But they're very young. Yes, but they did the job. Okay. So my team was done by students. That's why I'm not afraid to teach new people. Actually, you are highly qualified. Do you ever thought about that? The other option were students. And they're busy with lecture. So you're actually free and highly qualified. You are my best choice. I will not take a 60-year-old. I will not take a 50-year-old. I will not take a 40-year-old. Of course, if it's good, fine. If it's highly motivated, like one of 20s, it's fine. I want you. That's what I want. I want you highly motivated. Very sharp on technology, on everything. 360. Alexei is a lawyer. He answering linear regression, forecasting on computer. He's getting one of the places. I don't know which one, but he's getting one of the places because he's showing off. He translates me all the time. When people do not understand, go and help. Example. I never met him before last Monday, 1 week ago. See? So it's putting effort on it. It's helping the others to come out from going there. What is your problem on the computer? Helping me to the translation. It's functional. Good, fine. It's getting one of the position. I don't know which one. Maybe the one he likes. Maybe he gets the first choice. So, what is the strategy? I should go under him, or I should create my own group. Two different strategies. I'm working on your strategic way of thinking. What is your strategy here? Just sleeping here? Or are you creating your team? I want you to start to think about your team. Who will be my team? Will I be a leader or just a follower? I will be the shadow? Who am I? What is your strategy here? I'm pushing you. You will be not the same after 1 month with me. I'm forcing, I'm pushing pressure on you. She came Friday and said, you put me under stress. That's my job. That's my job. Not because I'm able, because I want to test you. Because if I put you in a wrong position, you will burn out in 2 months. You have to be resistant. If you cry, it's fine, but you have to stand still with your weapon on. So, this is how it's organized. I'm very scary. I'm more scary than reality, because I'm trying to save you. So I'm trying to put your pressure, thoughts, and thinking, but this is what I want from you, a response.
I would like to give them hope.
Oh, okay.
I work with Filippo with 2 years. Every day I'm a survivor. So this is a
Long-term survival. Eh?
long-term survival.
How many people have you seen near me passing by? She doesn't even remember the names.
I don't remember the name.
Beatrice is a survivor.
I'm a survivor, so.
But you can see, she's a lawyer. And she does project management. She's working on statistical data. Maybe, I know she doesn't like really much statistical data, I know her. But she tries hard. She's very resistant. Very resistant. She's the toughest person I ever met.
8 months.
Yes, but not just 8 months. She was under the rain every single day. Do you know Rocky Balboa? First movie, he just go up in the ring and just get punches everywhere. But he doesn't fall down until the end. He finished the game. It doesn't matter how hard I hit it, just she's there and she's there. And this is a very good thing. For example, Kelly doesn't have it. Kelly sometimes goes, no, it's a tragedy. no, stop. But she has other quality, of course. But it's a way. But today they're participating in big project. They were talking in Uzbekistan. They are running project in Kazakhstan. They're running project in Italy. They have a huge network. Patricia today was talking with the chief of Caritas of all Kazakhstan. What is Caritas? Is a no-profit organization from religious origins that take care about poor people. He can get funds around. He can create projects. And that's assuring your job in the future, because if you are where projects are, where the money are, you don't have problems with money. So the point is that it's not about this job, it's about the future. When I take you, I just throw you in the sky. I have to just be assured that you fly. But the point is this, you have to fly, and you have to think that you can fly. Because if I throw you up, and you have the wings, and you don't think you can fly, you will not move the wings, you will fall down. So I want to see your wings moving before I throw you up. That's why we're here. That's why I make these speeches in the late afternoon and not in the morning. Because in the morning, everybody's here. In the evening, only people that cares are here. You. So I've been working with people like you, around 200 now. 200 people. Approximately. I don't remember all the names. I'm forgetting who was that one. But 200 people.
So you are the godfather?
No, I'm saying that a lot of people usually, I have 90% of dropouts after 2 weeks. Within 2 weeks. Who survives 2 weeks usually stays. You have other 3 days left, and then you can consider yourself a survivor. Right? We have statistics on that. It's true. I will evaluate you all the time. I have my own way of evaluating you. How to evaluate my team. I evaluate people from 2 points of view. See, we are talking about indicators. I hope that all just will come because I'm talking. So, this is it. Coming. So it's coming. So, how do I evaluate people? That's a good question. Because we are talking evaluating doctors, we are evaluating teachers, how do you evaluate your team? This is how we evaluate our team. First of all, I don't care your background. We saw that it's not a variable that we care, because it's not predictable of anything. Where you're coming from, which university, not relevant. So for example, she has a lot of experience. So from the organizational chart, you would choose her. From my point of view, I can choose her, but I cannot choose her. And I will show you why. Imagine I get people from after a master, and then I get the students of the last year. Who will be in charge? Master? But if the master arrived yesterday, and the students was working with me since 3 months, who was in charge? Maybe the students. But then arrive a master, 50 years old. Who was in charge? Students. Why the students? Because he knows how to do the job. So, the first criteria is, do you know how to do the job? How do you assess that? First of all, use knowledge management. You write down all the things he have to know how to do. He has to do a pivot. He has to do a joint point analysis. He has to do a report. He has to do a balance scorecard. He has to do a graphic on Excel. He has to do you just write down all of them. When you write down all of them, you know what you have to teach. And you know how much time does it take. And the time is around 3-4 weeks. That's summer school. Huh? So, first level of knowledge is somebody told me that it exists. That's first. I don't know what is it. I know that it exists. So, do you know how to do a pivot table? Somebody told me that it exists. I have seen somebody do it. Okay? First level. I have seen it exist. Not theory. So I saw Katie doing it. Second level, I did it. I actually did it by myself. Third level, I made somebody else do it. Yeah. I teach her how to do it, and then I don't do it. She has to do it. Okay? What's the next step? There is no step. No. I don't care about controlling. The point is that she had the full growth. She has seen it, she has done it, she teaches somebody else that did it autonomously. So she is at the highest rank. But maybe she's very good, technically very good. I'm sorry, I'm always taking you, right? But she's very bad. She comes late to the meeting. She always yells. She treats other people very bad. Should she be in charge? I would not like a boss like that. He's not a leader, he's a boss. So we have another area. That is how are my relationships. How do I measure that? We measure that, I measure because there is no standards, I measure it with strawberry points. Okay? Strawberry points is what they do it like in the kindergarten with my kids. If you are good, you get 5 strawberry points. At the end of the day, who has the highest strawberry points get candy. Okay? Here's the same. So, for example, there is a meeting, you arrive late, you lose 5 strawberry points. We have a problem, nobody knows how to solve it, you do it, you get 5 points. We are all tired, so we'll finish tomorrow. Then you arrive the next morning and say, look, I could not sleep, I've done it. 10 strawberry points. She's in difficulties. She cannot come out with her project. You go there and help her. I see it. 10 points. Okay? So you yell on the corridor, minus 20 points. Okay? So at the end, if you are good technically, but you yell, you go back down. Okay? Maybe I'm not good technically, but I know how to make people work well. It's fine. Your team will work. So what is the candidate at the end of the game? We will have person number A, let's say A, not a number, A, that starts 6 months ago, or 3 months ago. And this is his path. And then there is another one that is 40 years old that start later, and it's like this. And then there is a new one came in, and it's actually pushing a lot on it. And going up. So a new project comes, new money arrives. Hello. We're glad to see you. Thank you very much. So I will give the first opportunity to choose to the first one. Do you want this? Yes, I like it. No, I don't like it. Then if you don't want it, we ask the second one, then the third one. And this, when you take a project, you are the leader. So actually, I'm selecting the best leaders. I'm selecting most prepared and most communicative leaders.
But between them, there will be conflicts?
No, because it depends on what you mean for conflicts. They don't yell at each other. Otherwise, they both fall down. If they don't help each other, they fall down. I don't know what you mean for conflicts, but I'm not blind. The best way is to not have conflicts, is helping the others. So, I leave the floor to our main speaker. And most of you already know from the other day, he gave a nice lecture. And today he will focus on data management and other type of indicators. I have a lot of big experience here. He knows also about, of course, databases, but also especially from ECD9. Do you remember we talked about DRG database on ECD9 today? So he's running a project on ECD9 collection of data. So he can give you a real picture of Kazakhstan today. So I'll leave the floor to my great friend, and I'll leave you the pen. Thank you for being here, because I know that you are very, very tired, and I will clean up the bar for you. What?
First of all, I'm sorry for being late, because I had a meeting. It's very difficult to manage time when you're working for the government. Second of all, today's topic is data management. Data management, especially in healthcare, and we need to consider that we have existing IT systems for the last 3-4 years already, which is helping to the medical organizations to collect the data. So first of all, we have 21 different information systems managed by the Ministry of Healthcare for medical organizations. That systems allows and was designed especially for collect the data from the medical organizations to provide medical services to the population in the frame of the guaranteed volume of free medical services. But right now it's a little bit changing. The scope of the system itself, not IT system, but the management system is changing because of the mandatory medical insurance systems coming up. So how it will change? Let's imagine we have so in here we have different IT systems. Here here we have medical organizations. And in here we have Ministry of Healthcare. So, existing problem right now is we have 21 different systems to collect statistical data about oncology, about diabetes, about the attached population to polyclinics, the polyclinic system, etc. But the main problem of the systems is when the system was designed, it was designed only for Ministry of Healthcare. So it's brought us to a situation here today that the medical organization, polyclinics, they're not satisfied. We don't like the interface of this system, we don't like that we need to re-input data from one system to another, not automatically manually. We're re-putting it. And if there's any medics here, they know that they hate the systems. They really, really hate it. And we do. I hate it too. But it's very comfortable and the interface is very good for Ministry of Healthcare. They can collect data very easily, like a click, collect this data, which helps them to plan the budget for the next coming years to spend around the medical organizations.
May I ask one question?
Yes.
Is the data that are collected complete, or there are some hospitals that do not fill them in, or there is like they fill it partially, or?
It's very easy. The Ministry of Healthcare thought about that someone might not input the data, so it's managed very easy. If you're not inputting data, you're not receiving money. So the hospitals, they're pushing to work with the system, even the system is not comfortable.
For example, today one of the professors this morning said that some people in, I don't remember, was it Tajikistan or something, they were, no, in Ukraine, they were, Russia. They were putting data also if the patient was not in the hospital. So you go in the hospital, it was empty, but it looks like it was full.
We have two phases. First phase, it's existing financing system right now. And second, it's mandatory medical insurance system. So in the existing systems, in polyclinics, for example, we have attached population. We have 4,000, 5,000 attached population. You're receiving money for 5,000. The 5,000 people might come or not, but you're receiving fixed financing every month. But right now, the system is changing with mandatory medical insurance fund. The government says we will pay only for provided medical treatments. If there will be no patient, there will be no money.
But how do you know if that person, like today they told us, like I remember it for Russian.
There was a.
I know that experience. I know that experience that we have existing IT systems providing in Russian Federation when they putting any name or any identification number and aligning to the medical treatment. And the patients next year finding out, oh, I got treatment last year, I didn't even know about it. But right now, we want to avoid that problem. We developed the interface with attached barcode scanner. And we have, all of us, we have IDs with the barcode printed out on that ID. So we're scanning out the patient when he's coming to the hospital. Use his barcode, no manual input data. Identification of patients, per stage. But now, it's the polyclinics receiving only for attached population. They are collecting the patients, for example, right 2016, in September, they open a campaign, attached campaign, they come to us, please attach to our polyclinic, and they tell the Ministry of Healthcare, oh, we have 10,000 population in our area, and give us money for 10,000 in 2017, coming year.
One question, usually the district polyclinics are not under the Ministry of Interns.
Ministry of Healthcare. They're under the local municipalities.
But the local municipality is not under the Ministry of Health, but it's under the Ministry of Interior. So actually, they are not under the Ministry of Health. They are under
local municipalities under the president.
They are the president.
Yeah, direct management.
Yes, but it's not under the Ministry of Health.
Medical organization right now have two sources of financing. First, it's from the local budget. It's like tuberculosis treatments and etc. Very social, high effective diseases. the local municipality gives some finance. And we have a guaranteed volume of free medical services provided by the government. It's from Ministry of Healthcare directly to that medical organization. So polyclinics, other hospitals, and we have another, it's high cost medical treatment. It's still from Ministry of Healthcare.
Okay.
So actually the most, like 85–90% of financing from Ministry of Healthcare, but they belong to the local municipality.
Okay.
It's worked like that. So to receive this amount of money, they need to input data into 21 different IT systems.
It's hell for doctor. Spend more time in working than it's on typing data than seeing the patient.
So right now the doctors, they're really unhappy because even not input data, they need to paper journals, paper records. So doctor, he putting paper records, he re-inputting in the system from another system to another, re-inputting again, re-inputting again, re-inputting again. Afternoon, the nurse going to their local area to check their local attached population in their houses with the paper. So imagine they coming out from work like 11, 12 midnight.
And the coding system is based on ECD9.
Yes, and right now we are shifting to ICD-10.
So in theory, we can compare hospital from here to Italy because we are also using ECD9. So we can, but we have DRG.
We have DRG, but right now the DRG it's okay. DRG, can I use this?
Sure.
Yes, but give me some time. I'll explain it because it's really difficult to do.
Okay, sure. DRG contains from 2 lines. First is medical treatment, which can be standardized according to international standards, no problem for it. The second line is administrative costs. It's like heating system, electricity, etc. So consider we have huge territory, and we cannot make one DRG for whole Kazakhstan. Because south part, they can save up money because the one DRG, they have saving up money. The north part, they like 6 months, they're spending money for the heating system, they're spending more. So right now, DRG is still in the process of the formula. We have DRG, but it's not that effective as we.
But you can create a DRG because it's an algorithm from the ECD9.
Yeah, sure.
But it's not attached to economical point of view.
Yeah, exactly.
But see that we are comparing the DRG for pathology, not for the money. We can actually benchmark hospitals because today we had a lecture from Italy from the system that you monitor all the region and all the hospitals, and they compare each other with the benchmarking. We will forward you also this thing that in English they will send today. And but the point is that we can actually calculate the same indicators for this that are calculated there.
Yeah, sure. From the system, you can take out statistics and you can compare easily. It's very easy, no problem.
And for example, I was in Almaty running a hospital, and it was not recording ECD9, and it was 2013. And actually something changed. That's why I'm asking. Like
2013 just started to.
Started. So now everybody's collecting data. Okay.
So Unity considers that from 2013, when the project is started to be implementing until now, we have approximately around 11 terabytes of data about all provided medical services for all population and foreigners.
And who is analyzing this data?
We have another center, Republican Center for Healthcare Development.
That will come to teach us in the next days.
We're exporting out the data, we're collecting all the data into one and giving it for analytics. They're analyzing like, what has changed, how it's changed, what is influenced on outer reasons, inner reasons, why the data is changing. So only for technical support, development, technical development, integration, and etc.
And this is very important because it means that if tomorrow we get a hospital, we will have data that we can calculate the indicator that we were talking today late after lunch, the other speakers. Because we will have data of DRG, ECD9, and so on.
And right now, the mandatory medical insurance fund require our systems is only for record for provided medical services. But right now, fund says, okay, I want, for example, IT or hospital information system plus ERP.
Do you know what these two things are? You have to ask a question when you don't know.
ERP. It's ERP. It's not translation. ERP. I don't know. I don't know Russian.
ERP is...
Enterprise resource planning.
So what is it? What do you think it is? It's about money.
Right
I'm
now-
wrong. It's about the economical part of the company.
From January 2018, everything becomes about money.
Yeah.
Because fund have a limited amount of budget, and the fund need to have tools to manage which hospitals needs give money for provide medical services.
So one second. That means that I'm trying to link what you say to what we have done today.
Yeah, okay.
So he's actually saying that it's about money, and when it goes like this, means that if you are doing good, you get money, you survive in the market. If you go like this, means that you don't survive the market, you close it.
Yes, exactly. Because right now, all medical organizations saying, okay, we spent this like 1 billion tenge, and the Ministry of Healthcare covers that 1 billion tenge. But according to international research, that amount, like last year, it was 60 billion tenge. 60, no, not billion, миллиард. 60 миллиардов тенге. Huh? Billions, okay, 60 billions tenge. And it will increase up to 90 billion in coming 2-3 years. So you can imagine how the spend for the healthcare is increasing very rapidly, and the government. There's two ways. One way will be keep financing as today without any mandatory medical insurance fund, and the healthcare area will be bankrupt. Will bankrupt the country after 2-3 years. Or the second one, we can reform the healthcare area through the medical insurance fund, but the medical organizations need to plan their medical services. Not like now. I spend like 1,000 tenge, give me 1,000 tenge. No. I'm planning to spend 500 tenge this month, so the fund will cover me 500 tenge.
One thing. He's talking about planning.
Yeah, sure.
How do you plan? As we spoke yesterday and today, you plan on the past, forecasting, analyzing new things that are coming. This is how you make the budget for the future.
Yes. So right now we have committee for paying. I don't know. Комитет по оплате услуг. Committee for paying provide medical services. They planning every year according to historical data. They analyzing medical organization number 1. In 2016, they spent, like for example, 1 billion tenge. So they plusing 7% of the inflation, plus 7% of inflation, and according in 2017, this medical organization will receive 1.2 billion tenge, for example. But it's not mean that this planning is correct. Because so what's the hospitals doing? I have 1.2 billion tenge to absorb. I have to absorb it no matter what. So increasing the patient numbers, increasing the high cost medical treatment, etc., 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 to absorb the money. But it's not meaning the quality of the medical services is on the same level or increasing. So medical insurance fund says, okay, we'll not be analyzing historical data. We'll be analyzing provided medical services. Medical organization provide medical services. If there's no bad feedback from the patient, we'll give you money. If there will be some bad feedback from the patient about received medical services, you'll not be receiving money. So in here, to make that decision, we need IT systems to collect the data, because without IT, the hospital or the fund or etc., it's impossible to manage fraud management. It's like fraud management very crucial here. Yes.
See how important he's talking about, not something global. He's talking about the strategy that the ministry has, and he's talking about data, money based on money given by data, and on performance, not only on data but on performance. They are not talking about the old system, we are talking about the new system. And if you are not in the management system and you don't run properly, you close.
So, for example, we have data from 2013 about provided medical services, but when we're starting to analyze how effective it was, we fail because we don't know. We have only number and we have list of the medical services to provide for the public. Yes.
Actually, I had a question, but you can finish and I ask it later.
You can ask now.
Okay, so you said the criteria is opinion of the patients about the medical services provided. So, good results, you're getting money, not so good, you're getting less money. But it's rather personal, like assessment of the medical services provided is rather personal. So, how you'll be collecting this data? Because yeah, they did something with me, I got something, but the doctor was ugly, I don't like him.
Okay, let's talk about the situation now and how it should be.
Yeah.
Now, the patient comes to the Department of Healthcare in the municipality and complains, I don't like the treatment I received in the hospital. The Department of Healthcare had two choices. Says, okay, just be calm down, and just, and he said, okay, I'm calm down, take out your back, your, I don't know, complain. Take back your complaint. Okay. The second one, I will receive your complaint and I will punish the medical organization. No matter it's the medical organization provided proper service or not, I don't care. I need to punish it. So right now, the local healthcare department, ministerial healthcare, different committees, they're only punishing without investigation. They receive complaint, they need to close it. So right now, how it works? I'm coming to ministry, I'm give my complaints and say, we receive a complaint, don't worry, we will punish him, he's so bad and you're so good. But it's not meaning that medical doctor provided bad service. Maybe his breath was bad after last night party, who knows, maybe he was not shaved, maybe, or maybe he was rude because he's a doctor. I have some doctor relatives, they're very rude, they're not nice persons in the
especially surgeons.
Especially surgeons. Especially in the emotional ways, they're really rude. But it does not mean they're not professionals. They really are professionals. So, how IT can help us to manage that situation? The IT can help us to build up the web portal. The IT can help us to manage the complaint system and track the complaint system. And right now we're in the process of building up that system. We're calling it. I forget the name was Третейский суд, как называется?
Oh.
Independent evaluation system.
Arbitrage.
Arbitrage.
You know
So it's independent evaluation system which we can attract as a people and is independent doctors. For example, if the complaint was about the therapist, we can attract another independent therapist and say, according to ICD-9, does the medical service was provided badly? Can you check? He'll open a system and say, okay, the patient came, he spent 20 minutes to diagnostic him, he provided medical services, there's no worse condition after that. So why? What is the complaint about?
I want to show that what he's talking about is what it's in place now. It doesn't mean that the entire system will go around only on this. Next time we will say, okay, because, for example, this is not for appropriateness, because I can go there, I'm an old person, I talk with the doctor says, if I give you too many medicine, you will be more sick than what you are now. So I'm not giving you medicine. So he goes back and says, he's a bad doctor because he didn't prescribe me anything. So he goes and complains. That means that it's not true, that he's a bad doctor. Maybe it's very good, appropriate doctor. So the point is that, but at the moment, they can only monitor this. That's why they're focusing on this. That means that if they evolve, they will find other ways to not pay you. That's how it works in other places. I will see that your appropriate way of treating this patient is not correct, I'm not paying you. You keep this patient too much, I pay you only half. And so I always cut money. The system is about cutting money. So to force you to be in the truck. That's how it's working in Italy as well. I pay on this patient should be only for 10 days. If he stays more, you pay it. I'm not paying it. So, or you have you didn't collect the data properly, I'm not paying you. You didn't send in time, I'm not paying you. So it's just starting the system. Now it's about complaining because it's easy. The next one will be you didn't fill up very well the chart. Because now, imagine if the doctor had to fill the paper, maybe more papers, all these databases. When it fills up, we just make the minimum requirements. I need one diagnostics, I just write one. Then it looks like that they are all easy patients, because the system analyzes the patient on how many things you wrote. So if you say diabetes, then it's just a diabetic patient. But you were lazy, so you didn't write that he had bad foods, a patient with complicated adversity, then he had heart problems, he had lung problems. You didn't write all these things, so it's not complex, it's easy. So I would pay you only half of the price, it's easy. If it was higher, so in this way, what happens in Italy? In this case, private companies put a lot of pressure on doctors to write everything. So when you go and see the data, private clinics looks like they are doing like very difficult cases. And public hospital, where they don't push pressure because who cares, it's they looks like they're not doing anything, but it's not real. It's actually the opposite. I'm just
sure. So before the IT system for last 4 years from 2030 was implemented, the question was, we have bad health condition in some areas in Kazakhstan. How to fix it? Previous ministry said, okay, we need to invest more money. We need to build up hospitals. We need to build up polyclinics. We need to buy expensive equipment. We spent from 2010 and in 7 years, we spent 2.5 more investment money into healthcare, and it was 7 years ago. So logically, when we invest more money, we need to receive more results. But it's not happening. We have same condition as mother's death percentage as it was 7 years ago. We have the same percentage of the children that like 7 years ago. Nothing changed. It changed like 1-2%. But we invest more money, 2.5, like 250% more. But there's no feedback.
Because lifespan increases year to year.
Но это не влияет на материнскую смертность. So statistical and the special centers, Republican Center for Healthcare Development, they need to analyze why we invest 250% more money, but the feedback is very low. But there is no data. Okay, from 2013, the data coming out together, collecting from all medical organizations to collect data about provided medical services. So right now, 4 years passed. We have right now historical data of 4 years provided medical services, and 2 months ago we made the analytics. We realized right now the ministry is implementing project. It's called, I'm sorry, that.
Do you understand that what I was telling you before is real? He just came from the ministry. He works there. And he knows what things are doing. You see, it is very aligned with what I'm talking about and the tools that we're studying. We are the future.
So, when we're starting to analyze what's the reason of that, the disease level is not decreasing, we cannot understand. Right now, we understand that the reason is right now the program of health, disease management program right now is implemented in 5 areas. It's diabetes, hypertonia,
сахарный диабет, diabetes, and
oncology.
No, oncology. 3 нозологии.
5 нозологий.
5 нозологий?
Нет, 3 нозологии опытные. It's pilot projects in three diseases, but in general we have 5 right now which we want to implement. So we have focus groups in the medical organization. We have focus group of the patients. So the polyclinics and hospital teaching that pilot focus groups patients to manage their healthcare condition. Health condition. So they helping them. Okay, you need to when you go home, you need to follow your diet. You need to sleep 8 hours. You need to. So actually, they're teaching them how to manage their health lifestyle. How IT can help. How data can help in this case. The situation is before, for example, the patient comes to the hospital, for example, before. It's one medical organization. And doctor. We have a doctor here. Doctor. And the game of guess why I'm sick starts. Initiating. The patient comes and saying, I feel sick. Guess why I'm sick. Doctor sends him to the laboratory, X-ray, KT, computer tomography, MRI, etc., and blah 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 blah. So, taking his all possible things to analyze, to guess what happened with him, you know. And it spends like how many? 1 week, 10 days, 2 weeks to gather the data. I've been in Korea a year ago. I saw, for example, right now, like urine analysis, right? It's called in English, urine analysis. My son is wake up in the morning, like 5 a.m. I'm collecting with a small can of collecting his urine and go to polyclinic, and it's sterile. In Korea, they have toilet seat with a special collecting place inside. You're just going to toilet, stand up, and all your data goes to your doctor, immediately to your polyclinic. It's the perfect example of collecting data, analyzing, and sending to the doctor. So in here, right now, that the disease management project, it's focused that people will be involved into the treatment process. Before it was patient comes and think, okay, let's guess why I'm sick. Guess why I cannot sleep for last 2 months. Guess why I have very high blood pressure. Guess, and doctors, he's spending so much time and analysis, and when you finish with one doctor, you're going to another doctor. What happens? Again, the second doctor saying, you need to take all this analysis again. You're going to another region, again, all that analysis, X-ray, urine analysis, blood samples, you're going the circle of hell again, because no data about patient is a system. You have right now no data about your blood type, about your urine analysis, about your X-ray. So we don't have actually electronic health record. Not now, not yet. We will have until end of this year. Right now we're in the ongoing project. So in the process. So December
Excuse me, before
2017.
I go to the point, can I ask you a question?
Yeah, sure.
So you've asked the question, why does the level of disease does not decrease? But you didn't answer the question.
Because the patient comes on the late stage. We have one joke. Why the ex-USSR people comes to the hospital before death, like before 1 hour to death? Because they don't care about predictive diagnosis. They don't care about their health until they start coughing. They don't care until they lose their conscience on the street. In the US, Europe, the people 2 times per year they're passing the medical checkup because they care about their health, because they're paying for it. As a medical insurance, they're paying money for it. They don't want to spend more money when they'll be in very bad condition. We analyzed emergency calls. We analyzed patients in the polyclinics. 65% coming when they're already in the worst condition. They're not coming. For example, I haven't been in polyclinic for the last 4 or 5 years. If I'm not lying, because I'm not coughing. I'm sleeping well, so I don't care. But I should. Maybe on the medical checkup, maybe they'll find something which is not right now obvious yet.
So, see, what he's talking about, it's what the rest of the world is doing. We will have a lot of data on anything. So many data. We are talking about big data. And on the other side, we were seeing today that our quality department do not have data. We asked them today, on what do you work? How do you create a strategic plan? Which flux of data do you actually watch systematically? And they say, none. Because one department of quality said, when somebody asks us, we make a survey on the quality of the lessons. Okay. And the other one, about clinical, says, oh, we check if the doctor have the qualification, the papers. But this is not a systematic way of getting data. We don't actually have data. And this is critical. How can we build a strategic plan? How we can build what to do if we don't know what we are? For sure, the first step is to make a picture of us to understand where we are, so we understand what we want. So it's very, very important. So now at the moment, we are talking about collecting everything, and in our institution, we don't even know who we are, how many people we have, who's getting the money, what they're doing, if they're treating patients, number of patients. We're not talking if they survive, if there is a mortality, if there is a quality of teaching, nothing. Everything has to be built.
Yesterday, for example, we've been in the polyclinic number 7 in Astana. We came, it was immediate decision, we didn't warn them. So we came to the hospital to check as they was implementing pilot project of implementing hospital information system in the polyclinic for the last 2 months. We came and we started talking with the chief medical doctor and asking, okay, how many patients with diabetes you have in your region, in your area? He doesn't know. Does that diabetes patients have invalidness? Disability. How many people of that amount of diabetes they have disabilities, they cannot physically come to polyclinics? I don't know. How much money do you receive? He knows very good.
Very well.
Yes, very well. He knows the financing. He knows how much money he spends per month, but he doesn't know about anything about its population in his area. How many percent or how many people of that in your area have mental problems? Disorders. He doesn't know. They're using the system for 2 months. They're inputting data, but they're not collecting statistics. They're not working with data. They have data there. They need to analyze it. So we went to statistical department saying, "Can you give statistics?" "Yes. Wait 5 hours. In the evening, I will give you a report." Why do I need a report when you can click like 3 clicks in your computer and you can extract data? No, I need to approve with my chief medical doctor. Approve what? Data from system? What for? I couldn't get it. I don't know. I call it's like mentality heritage. Like the clerk needs to go to his boss and approve everything. But it's data already in the system. It cannot be changed. It cannot be modified. It cannot be, I don't know. But that data is crucial for the money. Because if the amount of the patient not matching with attached population, then it means polyclinic receives more money than it should be. This moment, until now, was okay for the government. But for the last 10 years, the number of complaints is not decreasing, it's increasing rapidly. Government says, okay, we're creating mandatory medical insurance fund. It will be responsible for the quality. How? Through the tools of managing the financing the medical organizations. And for that, the data collection, data management, data analysis is very crucial. In some hospitals, we have hospital information systems, half automated medical information systems, but we don't have ERP. ERP, Enterprise Resource Planning, when all your processes attached to the money. You're receiving 1 million tenge, how are you spending according to the provided medical service?
One question. Do you work, see that you're working ELT on ERP. Are you, so who is giving the ERP software in the system? Is your institution or it's a private system? Let's imagine that our AMU wants to create an ERP for the university.
It's open market.
Open market, but so we just ask a tender, we make a tender, we take a, or can we apply to some of your, see that you are working on this data, instead of getting a new platform that doesn't match, it doesn't fit, do you have like a list of the
TDS.
Huh?
We have TDS.
TDS, yes. So just to understand where we should go, so that it's like we are talking the same language. Because sometimes we have data for radiology that one machine doesn't talk with the other machine. I produce things that I cannot see anywhere except in that one. So because there are private patents on that. So of course, when we were talking about this, if we implement a ERP here, means that we will analyze each single process and we will become accountable on the economical point of view. But the point is that he's saying very well, I don't know if you understand this point. He's saying, we will collect the data. we will know exactly what you are doing because the Republican Center of Health Development will analyze it. So we know actually what you're doing, but you are not checking what you're doing. And I'm coming to you and say, how things are going? How many patients do you have? Say, I don't know, but I know already the answer, better than you. And so the next question is, if I know you and you don't know you, maybe you should go doing a different job. It's logical, right? It's logical, it's just logical. So the point is, if they come here and they see, what are you doing? They say, we don't know. How many students do you have? 1,000. Are they male or female? I don't know, we have 45% male and 45% female. And then 10%, what are they? We don't know. That's the type of data we have. And they can complain because they pay for it. Sorry, I'm just like underlying what you say.
Yeah, sure, no problem. Yes?
In Russian.
Yeah, sure.
Вот вы сказали, что вы ходили в седьмую поликлинику и не мониторируется, да, количество человек, кто страдает сахарным диабетом. Почему, да, например, у нас возникает такая проблема? Например, вот есть управление здравоохранения, да, есть главный специалист и нештатные специалисты по определенной специальности. Проблема в чем? Проблема в том, что они не могут правильно организовать именно пойти, вот внештатный специалист, да, эндокринолог, он должен организовать вот этих людей, да, и брать, как контролировать, и чтобы все знали о численности.
Нету мотивации.
Мотивации.
Нету мотивации, потому что because the doctor receives fixed salary, he doesn't care about his population.
The question was that they went to polyclinic number 7 and there was no monitored population with diabetes, and so try to explain that the problem is that specialists from the staff or from not from the staff should organize these people and control full the process, monitoring the data, but lecturer a bit disagrees, said that there is a lack of motivation because for doctors it makes no difference, like is it collected or not.
Simple example, for example, current condition of between the medical organization and financing that area. Example that I was a child until like, I don't know, 13, 12 years old. I don't care about money in my family. I just ask, buy me bicycle, buy me this, buy me Nintendo, buy me Dendia, buy me Sega. I don't care about income of my family. But I know that I want it. And my family, my father, he was until some age, he will say, okay, I will do whatever you want. But when I became 13, 14, okay, he starts giving me money, fixed amount of money per month. This is fixed amount of money. You need to survive it. I don't know. You can save up that money and buy Sega, Sony, PlayStation, whatever you want. Or you can spend it every month. You can buy cookies, you can buy sneakers, I don't care. But this is fixed amount of money which I will give because I know approximately how much you can spend. Right now, hospitals, every E complains we don't have enough money. But no one actually can check it, is it true or not? Nobody can check. But they complain, we don't have enough money, so prove it. So the main chief doctor comes with accountant with this pile of paper with many different numbers and proving you that money is not enough. I need more money. You see how much I'm paying for the paying for laboratory? Do you see how much I'm paying for heating system? Do you see how much I'm paying for electricity? Oh my God, I'm poor. I'm bankrupt. Give me more money. Do you see how many subsidiaries they have? Different medical organizations. I'm lack of people. I'm lack of this, and I'm spending this money. And the Ministry of Healthcare or checking organization, they cannot drill down all that paper down. They cannot check it. How that numbers formed. They can see only paper. If I want to see how that number was calculated, I cannot check because I can see only. They can show me the alternative commercial offers from different laboratories. Laboratory 1, laboratory 2, laboratory 3. They have lowest cost, for example, 10,000 tenge. But that 10,000 tenge actually covers that service, I don't know. Maybe it's cost 2,000 tenge. But he shows me 3 different commercial offers, and the lowest 10,000 tenge. It's how it happens now, because medical organization, and for example, they have planned amount of money every year, and what happened when they spend that money, for example. It happens correction. In August, they're saying, we finish all money, we need more money, or we will close up hospitals. They're blackmailing government to give more money. Otherwise, we will close our hospitals, the people will go for the protest, give us back our hospitals.
These things happens in Italy as well. When a department runs out of money, he say, I'm stopping working because this is my fixed budget, so I stop. The point is that it's not true, because you had to plan it before. So the answer to this was, how much do you plan? So you made a wrong planning, because I asked you for planning. That's why there is a negotiation with balanced scorecard. I'm asking you what to do, and you tell me how much money you want. We agree. At the half of the month, at the year, you run out of money, it's your fault. Then I will blackmail you, not me. I say, you close the hospital, I remove you. I put another person in charge to run the system. Because you planned it wrong. I don't have money. But we plan and agree, and you said yes, you sign a contract. Because when you are making management control system and negotiate with balanced scorecard, you are signing contract. So you lose your job. Are you sure you run out of money? No, it's enough.
So right now, all financing management, it happens in the 1S. Local municipality, Ministry of Healthcare, none of them, they cannot see what is happening in 1S. They're printing out, they can change numbers, they can do whatever they want, and put a stamp on it and says, it is final version of my calculation. And he comes to the ministry for payment. And if I start asking questions, he says, why, you don't believe me? Why, you think I faked that numbers? Do it. I can't, because I don't have access to the system. I cannot export the data and say, you see, I have access. If ERP will be implemented, then I can access to his system and say, print out all his income and outcomes and say, you see, in your system is another numbers. You show me with another numbers. So in that case, data provides proofs of the person, the company, organization who is giving the finance, like fund, Ministry of Healthcare, local municipality. There's no report.
For example, I arrived here, and the first things I'm asking data. I'm asking that in 2 ways. One, I'm asking a report. Please write me how much this department is consuming, this department from an analytical point of view. And you write it down, but I ask you to certify. You remember about certification? I certify, I put my signature, and I trust you. On the same time, I'm asking the database. My first day here, I went to the accountant and say, I want your database. I went to the Sirius and say, I want your database. But what do you want? I can extract it. I want the database. And say, oh, it's impossible to take it out. I say, no. It's too big for Excel. I don't want the Excel, I want the text file. Text file is unlimited. So I ask for a database on text. I say, it's not possible. You tell me what you want and we will arrange. I say, I want your databases. Because I already asked you the reports. Now I have the reports. Day 1. I went to the human resources, to the economic department, and to the information system. Here is called e-learning. I want your database. So we found out, because I'm asking the same questions. I asked the human resources, who is working here? And I asked to the accountant, who are you paying the salary to? And they must match. Because that means that otherwise I have some employee that I don't pay. Or I have somebody I pay that are not working. And nobody knows it. It's a simple question, you just have to match. But the answer is, we don't have it. Or what they do is like vomiting. They do a lot of things, but you don't understand what is it. Okay? So the point is that, but it's not complete. They vomit, but it's not complete. So a piece is missing. So I'm asking, okay, take your time. You have 20 days, you give it to me. All of it, in a database format, not blah, 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 in database. So I can reuse, I want this column. We prepared the letter, it's actually here. But at the same time, because it's actually easy to change the numbers on the total, but it's very difficult to change the number in the databases because it spends 2 years to change the database to understand how you have to come out with that result without making mistakes. So the point is, this is the letter, right? I just have to read it because I'm very tired, I'm always here. So the point is, at the same time, I already collect databases. I have the databases on my computer. Some of them are very difficult. The RP, here they use C1. They only use in Russia. So I had to find a software to extract the data. It was a .tt format. So which software will translate this? So we found the software, but it was running only on non-Italian computer, only on Russian computer. So we moved in Russian computers. Then we have to export it in an Italian computer. Now we have the TXT file. And it took me 5 days to obtain it. I had to pay myself the software to extract this package and discuss with the software. Like, give me this thing, it doesn't work. But now we have the data. My idea was working with you, but we have privacy problems. So we will work that as soon as we have the office.
Depersonalized.
Yes.
Depersonalized data.
But the problem now that I have like a lot of tables, and we have to reorganize them to see them. But I'm sure that if we give this package in TXT file to him, he like reorganize easily because he knows how to work on that. But nobody here knows about this. And the truth is that when he will unpack, actually I unpack it, when he will put pieces together, or the data management system or that we are building will reorganize these things, and I will teach you this during this week how you reorganize this in a proper way and understanding the data, then you clearly see that you have from 2011, and you have to see how it's if it matched with the balances. All of the balances are fake. Now we can actually improve it. We just need to reassemble it. And for example, they always say, I ask, okay, we should invest in people. Like this office, we have to pay the salaries. Say, we don't have money. So we have, I made the trend, we work on trend. And we see that the money from January 2015, the expenditure was like this. And then it was going down. And this was December. So why am I spending in December? Isn't it weird that I spend in December? I get the money, the income, in March. The government pays in March. And I spend in December everything. But this year, 2016, the Ministry of Health changed it, so it's not paying yet. So we are in June, and we don't have the money yet. Okay? And we don't have expenses. So now the money will arrive in December, and I want to know when are we going to spend the money. Because they told me that they could not buy my desk because they didn't have money. I said, okay, no problem. I will arrange myself in a small desk. But the point is, when the money will arrive, we could not spend it before because we had to wait for money. So actually we have a lot of money to invest. It's not true that we don't have money. Because the delay of the ministry actually make us saving a lot of money. And the point is, if I'm spending in December, maybe is that I'm saving money all the years. No, there's no money. And then when I see it, I say, okay, I have this pot and we split it as we decide. There is no logical in spending everything in December. There is no logic, except that in December we close the year and the budget. So we have to spend this money within December. Otherwise, the government will say, this is revenue, give it back. So the point is that we should see where these money are really spent.
So actually data helps to Ministry of Healthcare and to the Fund of Medical Insurance mandatory to proper manage the money. But okay, all of us, we are like citizens of Kazakhstan, and we think, I don't care about financing, what I will receive from the big data, from that remote monitoring and etc., what I will be personally receiving, for example. Right now we are in the ongoing project. We hope until December we'll be implementing it together with IBM. We call it artificial intelligence to analyze the big data. What it gives to the population. We have data from the moment you came to hospital until we receive treatment. If we'll be implementing the smart watches and like the smart urine system like in Korea, etc., remote monitoring stuff, IT tools, we will be receiving more data. We can receive data from your phone. How many walks, how many miles or kilometers did you walk? How many hours did you sleep? How many hours you just laying down on the sofa, etc. So all that data can be absorbed and analyzed through the artificial intelligence and says, you might say, I have a headache. Why? And system can analyze your data and say, for last 2 weeks, you've been sleeping less than 4 hours, and it brought you to the headache. For last 2 weeks, you've been moving less than 1 kilometer per day. You're sitting in the car, you're sitting on the sofa, you have like, etc., etc. So, but to that system to make work, we need data. Right now, data only from the moment when you come to the hospital, and the system cannot see what brought you to the hospital, what reasons brought you to the hospital, why you became sick. System cannot know because systems need to eat data. It needs to analyze data. But if there's no data in digital area, it cannot say you nothing. Okay, you get sick. For example, you get your bone broke. I don't know why. It just maybe broke by itself. But if you have your phone, we can gather the data saying, we fixed some falling down. Maybe you fall down somewhere and you broke your bone. And you can come to hospital. You can say, someone broke my bone. But through the data, we can analyze, no, you fall down. So data help us to analyze, to see the clearer picture for the patient, to analyze his condition. Or we can use, for example, your smartphones and all the sensors and etc. to make normal corridor. Let's imagine you have problems with the blood pressure. From 120 to 70, it's normal, right? 120 to 70, it's normal corridor. So every day you're checking through your Samsung phones, they have like, measuring your blood pressure system, sensor. You can measure today, it can be here. You can measure yesterday, it can be here, 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 here. So it's normal. The system says to you, you're okay. But let's imagine your blood pressure became 130. It's out of normal, or 60, out of normal. The system sends immediately sends data to your doctor and send you notification. Please go to your doctor or polyclinic or hospital because this condition is not normal. Same we can do with the sugar level. If I'm right, it's like 4.5 normal minimum and up to 6 or 7. 6 or 7, I don't know. If every day you measure, my mother, for example, she's diabetes. She's measuring her sugar level every day. But it's only she measuring, she can see the number, oh, okay, I'm okay, and she's go to sleep. But the doctor cannot see, system cannot see your everyday sugar level history. She only can see herself. Oh, okay, I'm fine, yes, I go to sleep. But right now it's already glucometers with the Bluetooth, with Wi-Fi, which can send the data to your phone and you can send to your doctor, and your doctor endocrinologist, how to say it? Endocrinologist. Every day he can in the morning can monitor his status in the polyclinics because he's responsible for persons in his area. He can say, I have list of patients with diabetes in my area, and today everyone's blood sugar level is like this. This one it's a green corridor, they normal. This one it's yellow, they not normal. And this one is red category. I need to call them up and make them come to polyclinic, or I can go to them. Rather than going to everyone, he can go only to critical area patients and save up time.
I want to tell you, today the technology is very advanced. Of course, he's talking about a lot of things that are, you need sometimes softwares or infrastructure. But actually, you have some tools that you can use it and you never thought about it. If you insert the data, for example, on Google Drive, he will make analysis for you. He will guess an hypothesis for you on the data. He will give you a sort of reports. It's a sort of artificial intelligence. Of course, it's not this level, but it can help you on the data because it makes automatically the data and the graphics and tell you even which graphic you should use maybe. So the problem there, of course, there is the privacy because you are going on Google and so you have some problems. But I want to ask, in the process, what office should we build to analyze our own data? What is the name of these functions? When you say analyzing, extracting the data, what are the official international names for that?
You mean like performance? Or
No, I'm saying like business intelligence.
BI.
BI, see,
Okay.
it goes BI because it's normal for him. Most of you didn't know what BI is or what business intelligence is today. But for you, it's clear. So, and of course, for example, data management. What is actually data management? Let's ask for definitions.
For example, we collect all this huge amount of data after 2-3 years, let's imagine.
To understand the process, though.
Yeah, we collect, and after 2 years, there will be meeting and there will be request. How many patients in Kazakhstan do we have with diabetes? 2 clicks, all your data will be on the monitor. How many of them they have disabilities orders? You have data on your screen. How much money government spent to treat the patients? You have data there. Okay, how much money we spent last year, and does the number of diabetes increase? Right now, for this request, we're spending 1 week, 2 weeks to gather the data, and we don't know even that data is correct or not. Because we had cases when we collect the data, we have 15,000 diabetes, and later on we found out that 200 of them already died. But we have old data. 200 of them died, but we're gathering that data for what? For proper planning of medical services and for proper planning financing that medical services. If we have wrong data, then we have wrong planning, then we have wrong financing, then we have wrong, very low, not low, but bad quality medical services. And right now, when we have wrong planning, the hospital, to not lose the money, they're doing everything to absorb that money. But it's not telling us that it's bringing us to the quality improvement. The quality is same. But money, its financing is increasing every month and every year. But the quality is not increasing. That is the question. So when the analytics starts trying to analyze what should we do, why it happened like this, there's so many wrong input data which can lead us to wrong decisions. That is a problem. And the first problem, if the data is manually input by the person, then it cannot be trustful. I will not trust ever to the data which was inputted manually by the person. I will trust to the automatically gathered data, because the machine or smartphone does have no interest to give a wrong data.
And what system for validation of the data do you use?
We don't have now. We just trust the data which existing in the system. We just trust the person. Right now, how it happens? I started asking a question a year ago. Why are we trusting that data which was input in the system? And especially saying, oh, I know that guy. He's very good at one. He's very honest. Hey, I'm an engineer. I'm technical engineer. I don't like humanitarian sciences. No offense, of course. But I never, when we programming some hardware and software, we cannot trust that on someone's honesty that he will input correct data. It's impossible. He can forget. Very common cases when the doctor need to input data, but he's too busy for that. He gives his ID and password to the nurse and say, input data instead of me. But she can put wrong data. She can't even understand it's wrong data. But it can lead us to the wrong picture of that person. If she'll put, for example, in the pharmacy, one small number of the milligrams, the system will think he has overdose, or he has not enough dose. But nurse, she cannot understand about it because she's not a doctor. She cannot understand the responsibility of the inputting data because the doctor, her boss, says input data. Here's my ID. We can find even stickers on the monitor with ID and password of that doctor. Information security. What are you talking about? Oh my God, it's impossible. We can find here the ID. Anyone, even I can sit on his computer when he's having lunch and put data in front of him to any person which I want. I don't trust the manually input data. Question?
I want to ask next question. Medical organizations get money for provided services.
Yes.
So I think it's, in my opinion, they will try to come people again and again to get more money.
Simple
and
example.
Maybe because of it, quality of service is not good.
How it happens now? We're planning money for 2017, as I told, based on historical data. For polyclinics, for example, we have 1 billion, okay, 1.2 billion tenge. So every month it's 100 million tenge. It's right now in the agreement. In January, you need to absorb 100 million tenge. But if in January there is no patient, how I can do it? I don't care, that's my problem. You need to absorb it. Or otherwise, next year, you will not be receiving money because I will be analyzing historical data and you will be receiving less money. So the hospital doing everything to absorb that money. They put in titanic efforts to absorb that money. They, for example, and they have many KPIs to receive that money. They're putting all that population through the medical checkups. They're putting all that population through the oncology checkups. Because they need to absorb that money. And they have additional KPI. If they will find some patient with the early stage of oncology, they will receive more money. They don't care about your health conditions, they care about money. Because they need to absorb it. But it doesn't mean that the quality will improve. No. So, the complaints, 62% of complaints, when the Minister of Healthcare and Committee cuts off money, medical organization doesn't care because it's, if I have too much money, I don't care about complaints. Okay, just penalize me, cut off money, I'll still have, it's like, for example, I've been in China in the market. For example, I want to buy an iPhone, for example. It costs $800. In China, it costs $300. So he said $800, I'm starting to bargain, and he sold me for $500. I'm so happy, I've bought for $500, but actually that person made a benefit out of me, he sold for $500. Same case here, when the Ministerial Committee cuts the money with based on the complaints, medical doesn't care about quality because they still have enough money. That is it's funny situation, of course, but it happens. This is it.
But someone is checking the reason of treating proper, was it proper treating, or what they get money?
We have two tools, pharmacological tools, to check the proper medical treatment process. First one, it's the system automatically takes 1 or 3 records out of 100. So 100 automatically picks up any case. So if we'll find out some mistakes, we'll penalize, of course. But if we'll not find out, then the 100 pass immediately for the payment. And we have another ones when during the medical treatment process, person died, we start an investigation. And he's not receiving money for that case until the investigation will not finish. But imagine 100 case, we're picking up only automatically two or three out of them. And other 97, pass automatically for payment. It's impossible to check everything. We just automatically picking up, and it's like, you know, like Russian roulette. Just let's send them. If they will find, they will penalize me. If they will not find, great. I'll not be penalized.
See, they did similar things in England. They go and check the records. If you fill it up wrongly, they don't pay you. But the point is that they, from the sample, then they extend to the entire population. So if I take a sample and 10% are not properly filled in, I'm not cutting those samples. I'm cutting proportion to all the patients you have done. So what happened in, for example, in one of our hospitals, that they were filling wrong the data. So actually, looking at the data, the inpatient was not appropriate. So the setting was not right. So they say, I will not pay you. But I'm not paying you only. Let's say I picked 100 patients, not only that 10 patients that they were wrong over this 100. I will take this 10% and bring to entire population of your hospital. So I'm cutting a lot of money. So one of these hospitals had a cut of 50 millions of euros. Can you imagine 50 million euros of cut?
50.
50. It's a lot of money.
Yes.
So they were in panic. They could not pay the salaries. Though they called me. I was telling the story about it to your man. They called me and said, we have to find a solution. So I said, okay, let's see. I checked and say, well, they are right. Yeah, we know they're right. We need to find a solution anyway. That's why we called you. So, okay, let's think about it. So the only way we get out of the system was because I analyzed how they make the job, how they sample they made the samples, because there are rules how to make the samples, and I found that they did it wrong. So I said, your testing system is invalid, so you cannot cut. So at the end, they went bargaining and say, okay, let's cut only 25 minutes. And we actually saved 25 millions of euros. So in that moment, I could stay in my life in Bahamas, not doing anything, just with one move. But I'm still here working. So the point is that if you analyze data, and you analyze policy on how you analyze data, because you need policy on collecting data, policy on how we analyze data. That's why we create a policy office. Because the policy needs to know about data as well. That's why everybody is listening to everything. Not because they will do everything, but because they need to know how to connect with the others and play as a team. I cannot play as a soccer team. In a team, I don't know what the goalkeeper is doing, what his function is, because I will not use it properly. So the policy is important because they have to write policy, how I collect data, how I analyze data, how the people should give me the data, and so on. It's very important, even if they don't do the data extraction and so on, because they have to work on process. Sorry if I interrupted.
No, it's okay. So it's generally like basic introduction to data management. Right now, so okay, it's situational what happens now. So right now the Ministry of Healthcare really put a lot of efforts to maximum. Why you're reading in the news like, Ministry of Healthcare want to informatize the medical healthcare. Why? Because Ministry of Healthcare needs correct, proper data to analyze what we're doing wrong to provide good medical services. Because when we're comparing to the OECD countries, we're spending very good money for the healthcare. But the complaining is not decreasing. Complaint level not decreasing. And some KPIs of the healthcare conditions is not getting well, not going well. So to analyze that, we need the data. For collect the data, we need hospital information systems plus ERP in the medical organizations. Plus, we need the patients be involved in their own health management, their own condition. So if they will input data, and if they will be inputting data into EHR, and later on hospitals cannot put additionally charge, like, I treat that patient, and if the patient put in his EHR, I'm healthy, so the hospital cannot use existing digital data for fake services, because he's healthy. Why should I treat him? So right now the most crucial part to proper analyze, to get proper data through the implementing IT in the medical organizations is very, very important right now.
Can I ask a question? We face these things also during our course several times. And the point is that most of the people says, okay, I'm working for the government, it never happened really anything, so what if I don't collaborate? I fake to collaborate, but I'm not collaborating, and just wait that the waves pass. We will wait the next ministry. So I will say, yes, yes, I'm collaborating, but I will not do it. What would you respond to these people? Because we are here because we are creating a team that wants to make a change. And most of the people we will meet is, okay, yes, yes, I will collaborate, but actually I will not help you because I'm waiting that you, the ministry, you, and all these people will just pass by as a wave. What do you think?
Okay, as an engineer, I can say that the people might, or the situation might not change, or the participants might not change, if the outcome factors will not be influencing on situation. Right now, we're in the process of the globalization, we are in the process of the financial crisis, etc. We cannot live in the closed loop like North Korea, without interacting with other world. It's impossible. So if we're interacting with other world, we need to, accept the rules of the game. And if we're accepting the rules of the game, we need to change. If we will not change, then no one will come and with a magic stick will not solve all your problems. It's impossible. But we need to understand, everyone says, why we cannot just buy ready data management system from Italy, from US, from Europe? You need to consider that our healthcare area was developed by the different rules until now, for last century. It's different mentality, different methodology, etc. We cannot break everything and put. I had some few specialists. They saying we have a very good example in the United Arab Emirates. We implementing a GSI, etc. international standards. I told, United Arab Emirates until 1970, they didn't have nothing. So it's easy to build up something on the empty place. But when you come in ex-users countries, we have very good background history of medical treatment, medical procedures, doctors, etc. We have societies, associations, etc. It's not easy to build up on something when you already have. But we need to combine, and on the technical level, we can say that unify two systems and to get the best out of it. For example, I can say that in the UK, the waiting list in the polyclinic or the inpatient procedure, they have even jokes and comedies how they're waiting per 6-7 hours. In our polyclinics, it's 15 minutes, and still people complain. But people always will be complaining. It's impossible. But at least if we will be like your case, your future health doctors, health management specialists, if you'll be open for discussion with your clients, the patient is client. If you'll be open to discuss with them, we're doing like this to make your life better, and not you're stupid, you don't know anything, just leave me alone, I will do everything for you. It's not the same time anymore. If we will be open for discussion, we can change something using existing resources to improve something. Not complaining we need more resources, because resources will be always not enough. But at least we can proper manage. It's mine.
Okay. I think that today it's everybody's very tired. So, but we will have a lecture tomorrow. So we will keep going on this subject. And I want to thank very much our speaker, because he gave a great view on what's actually going on. And we understand that what we were talking before, it's real, it's not fake. And that is going to happen, because it's not because of the ministry, because the change is going there. So all the world is going there, and we will get there anyway. We can get there walking, or just somebody will pull us. So I thank you very much, and we will wait for you tomorrow.
Thank you.
Thank you very much. And we appreciate that you came here also late in the evening after working all day, because it was not like playing or being on the beach, and he was working with a high level with a lot of stress, but he came here to teach us. So thank you very much. Thank you.
See you tomorrow.
Let's open those for
Students, you can vote at home, on your mobile, on the bus, whenever you want. It's open until tomorrow, okay?
How much questions?
One question.
One.
Just let's do like this. We will vote tomorrow morning when you arrive early. We will open, so today it's a long day. Go home and relax, okay? It's correct that you relax. Being a long day.
Okay, done.
Tomorrow is first. Beatrice, first part of the day. Yes. From 2 o'clock in the afternoon. 2 o'clock.
Yes, actually, I just need to cut some parts, like with your elections and stuff. So, and another question. Remember I was talking about loyal changes. It's just draft. Yes, they haven't found final version. So I read it. Some of them is just like a dream. But if you want, it's like only 3 pages. I can translate to you with my notes.
Them together with yours. So you will do it in the classroom.
Yep.
So it's and we will take notes when you
It's much easier to translate before to legal language. On my translation to Russian, into English would be like "and" something like that.
You know how to do it.
Yeah, okay.
I trust you. Подожди, я же folio firme Agrin.
Айганым.
Checklist.
What for you gave it to her?
So you can give it to
Green.
Just give it to Green. She knows what to do.
Quando
presenta?
Però lei l'ha mandato però non lo so, spiego poco così. Да, я сейчас не съезжу, открою эту комнату проветриваю.
Ты оставишь или тебе все равно?
А? Они завтра приезжают в город, когда я работаю.
В принципе, вот это замени на толстый. Это не
Sì, infatti mi hanno mandato adesso i menti, ho girato, non l'ho dato come c'era visto smono.
А чего кирпич?
До свидания.
Ночи, bye. Come è andata? Che oggi è abbastanza
Però secondo me perché io che non vedo
Allora vi sto lavorando sui dati, gli indicatori, verso.
Что? Ты же сказать невозможно вашему не верить.
Это почти как бы Word, но не для нас. Найди мне еще одного черного.
Lui ha detto è vero.
А тебе синий.
Devi pagare troppe cose.
Все, держи зеленую карту. Не, ну значит уже нет, зеленую давай.
Si possono qualità percepita dell'utente, qualità percepita dell'utente. Cioè, una cosa vero, padre, noi piano piano da 6 mesi